lighter one to introduce everyone to the concepts of pediatric sleep medicine with touching upon each and every disorder to a small extent, but the remaining ones will be extensive. So we all know that cats sleep 18 hours a day. So, and they are one of the most agile creatures in the world. Maybe sleep is related to that, not sure. So our agenda goes like this, like why is sleep important to children too? And how is sleep regulated in short? What constitutes normal sleep in children? And what is the prevalence of sleep disorders, especially in Indian context? Classification of pediatric sleep disorders and in special population. So I need not tell much about what are the consequences of sleep disruption in children, but I'll just touch up a little bit on that. Hyperactivity, inattention, and scholastic drop is very much seen in patients with kids with pediatric sleep disorders. Behavioral problems like aggression, impulsivities are also common. Even allergic rhinitis and immune dysfunction has been connected to sleep disruption in children. Risk of anxiety and depressive disorder in adulthood for kids with sleep disruption, and cardiovascular risks as equal to adult population like obesity, diabetes, and hypertension are also equally common. In adolescence, mental health issues and academic drop and substance abuse have been recently documented to occur in patients with pediatric sleep disruptions. So in short about sleep pathway, so the light that falls on the retina is taken by the retinohypothalamic tract to the sleep centers, especially circadian pacemaker, hypothalamus, thalamus, and the pineal gland from where melatonin comes. So all this have downstream signals to all parts of the body. So even physical and mental health as well as sleep health are all interrelated by this pathway. So the next regulation of sleep, the two processes which we should know, at least in short, is process C, which is the circadian rhythm, where the probability to fall asleep increases throughout the day and just peaks before the night's sleep starts, which is tightly regulated by light exposure via melatonin. The second process is process S, which is the homeostatic process as in other cells and organs. The sleep pressure increases progressively throughout the day and has been proved to be high just before getting into sleep and slowly diffuses overnight and will be the least in the mornings. So this is the second process which is tightly regulated. So both process C and process S goes hand in hand in regulating sleep. This is common to both pediatrics as well as in adult sleep. So now we should know what constitutes normal sleep in pediatric population. So that differs with age. So a newborn usually sleeps between 14 to 17 hours, which may be even as low as 12 to 13 hours or maybe as high as 18 to 19 hours. And slowly, as you can see, that the sleep hours slowly decreases when the child grows. So the usually adult sleep requirement of 7 to 9 hours is usually attained by the age of around 15 to 18 years of age. So we should know that it is even different in different cultures as well as in different ethnicities. So studies are yet to come in India about how different it is and what is constituting a normal sleep in Indian population or Indian kids. So this strict duration range for each age has to be taken into account when we take sleep history, because a sleep duration that is very, very low for the appropriate age becomes a main problem. And coming to a single night sleep, what constitutes a normal sleep architecture increase? Usually, we start from wake stage, enter into non-REM, that is N1, N2, N3, slowly from N1, N2, N3, and we stay there for some time. Then again the cycle backs to REM, then again it goes back to NREM. So here we can evidently see the initial half of the night, it is more of NREM or deep state sleep, and the second half is most of REM sleep. This is of clinical significance because the REM behavioral disorders are usually common in the second half of the night, whereas NREM parasomnias are in the first half of the life. And we all should know that the initial half of night constituting of NREM sleep is very important in growth hormone, brain recovery, and executive functioning. So any disorder that is affecting this part of the sleep will have effect in all these domains. So coming to the prevalence of pediatric sleep disorders. So pediatric sleep disorders are very, very common, even beyond our imagination, because we are yet to get the actual prevalence in Indian population. So this is a study from 2008, which was an epidemiological study, and it was just a questionnaire-based study, where you can see the commonest symptom snoring, which we all know, is 12.7% prevalence, and sleep disordered breathing was around 5%. The sleep deprivation was around 32%, which is 1/3 of kids were sleep deprived. And any sleep disorder, if you take into account, comes around 50%. This was the plight in 2008. We should note that this was a survey-based study and should have underestimated or even overestimated the problem. And it was in 2008, and the pediatric sleep disorders have been continuously rising over the years. So the present prevalence will be very, very high. So now coming to the proper classification of sleep disorders, these are the broad 6 groups of disorders which we usually encounter, of which insomnia disorder, that is behavioral insomnia of childhood, is a classical example. Hypersomnias of central origin, narcolepsy is another very good example, and Klein-Levin syndrome. Circadian sleep-wake phase disorders, childhood sleep disordered breathing, where OSA is a classical example. Sleep-related movement disorders, restless leg syndrome, periodic limb movement disorders, and parasomnias, which could be either REM or non-REM parasomnias, of which insomnia disorder and childhood sleep disordered breathing are our main interest today, because they are the most common, and out of which insomnia disorder is the most common sleep disorder in pediatrics, as prevalent as in adults. So I'm going to touch upon the remaining 4, just a few lines on each of this to give you an introduction about it. First, coming to hypersomnias of central origin, these are characterized by excessive daytime sleepiness, not due to any other disorder like decreased sleep or any misaligned circadian rhythm. And excessive daytime sleepiness is the most common symptom of these group of disorders, which includes narcolepsy, both type 1, type 2, idiopathic hypersomnia, and Klein-Levin syndrome. Coming to the circadian rhythm sleep-wake phase disorder, these are chronic or recurrent sleep disturbances due to alteration in the circadian system or misalignment between an environment and the circadian individual's sleep-wake cycle. These includes different types like delayed sleep-wake phase disorder, which is very common in adolescents and young adults, advanced sleep-wake phase disorder, which is relatively rare, irregular sleep-wake rhythm disorder, common in neurodevelopmental disorders, and non-24-hour sleep-wake rhythm disorder, usually common in blind children, jet lag disorder, which is temporary, which we all would have experienced, and circadian sleep-wake disorder, not otherwise specified. So coming to the next one, sleep-related movement disorders in children typically disturb sleep at its initiation with a stereotyped simple movements, may or may not be aware of the movement, which includes restless leg, which is a classical example, and it is even common in adults too, and periodic limb movement disorder, sleep-related bruxism, sleep-related rhythmic movement disorder. We have to note that there can be some isolated symptoms and normal variants in movement disorders like excessive fragmentary myoclonus, sleep starts or hypnic jerks, hypnagogic foot tremors. These can be just normal variants or could be a disorder associated with other movement disorders. So coming to the 4th group, that is parasomnias, which are undesirable physical events or experiences during entry into sleep, within a sleep period, or during arousals from sleep. These could be either NREM related based on the stage at which occurs, REM related, and other parasomnias. So NREM related parasomnias are disorders of arousal resulting from incomplete arousal and transition between an NREM stage into wake stage. So the classical example would be confusional arousals, where even our kids would have experienced. They might wake up confused, maybe crying for a few minutes and then going back to sleep. Sleep terrors, somnambulism, which is sleepwalking. The other group of NREM parasomnias can occur due to partial arousals in slow wave sleeps, which includes night terror, rhythmic movement disorder, nocturnal enuresis, and sleep paralysis. REM-related parasomnias, the classical example would be a nightmare, which usually occurs in the second half of the night, where we'll have vivid remembrance of the events. Sleep groaning or catathenia is the other group. So coming to special populations where sleep in genetic syndromes, I'm just giving you a brief idea where it will be discussed later on in sleep disordered breathing topic. Obesity and pharyngeal collapsibility associated with syndromes increase the prevalence of OSA or a sleep disordered breathing. Example is Down syndrome, where some of the unfavorable anatomy like craniosynostosis and peri-Robin sequence can also account for the increased prevalence of SDBs. And Smith-Magenis sleep inversion is a typical example of specific sleep disorder. Circadian disorders, behavioral insomnia are all common in all other genetic syndromes together. Coming to sleep and neurodevelopmental disorder, autism and sleep is tightly linked, where there is increased prevalence of insomnia, higher rates of parasomnias, Even up to 80% of autistics experience a sleep disorder during their lifetime. They have generally less REM sleep, and RLS is also common. So the take home messages for this one is pediatric sleep disorders are highly prevalent and highly underestimated. Prompt identification of sleep symptoms are very essential in picking up sleep disorders early in children. Sleep deception and sleep disorders are detrimental to mental and physical being of health. So let's all join hands to make our little angels sleep better. Thank you.
Very good morning, everyone. Firstly, huge thanks to the organizers, SKS Hospitals, and a big thank to Dr. Rajagopal for having us here today. Uh, it was a brief introduction to pediatric sleep, and now I'll be taking you towards the evaluation of pediatric sleep disorders. There will be a few overlaps, and this is basically just to sensitize the pediatricians here as to what questions that we can ask in our clinics when we see a child with suspected pediatric sleep disorders. So as we already mentioned in the previous session, the sleep requirements changes as per age. As we age, the need to sleep reduces, and as we age, the amount of sleep that we require also comes down. On an average, an infant sleeps anywhere between 12 to 16 hours, including naps, and then teens require lesser amount of sleep. The duration of sleep ranges from 8 to 10 hours. So when we see a child that presents to our sleep clinic, these are the predominant complaints that they present with. First one is difficulty in initiating or maintaining sleep. This is a yeah. So this is a complaint that we see in our children who are suffering from insomnias. And excessive daytime sleepiness, as Dr. Rajagopal already mentioned, it could be a soft sign that the child probably is having an underlying narcolepsy. But although narcolepsy is very rare, the other reasons to as to why a child presents with excessive daytime sleepiness is probably sleep fragmentation itself. And excessive daytime sleepiness in the children, they present with irritability, hyperactivity, and inattention. I know the second part of today's session will be on neurodevelopmental pediatrics, but many a times children who have been mislabeled as ADHD have found to have only poor sleep, and that is why they're probably behaving inattentive or hyperactivity during the school. And the most important complaint that we see in our clinics are snoring or other sleep disordered breathing complaints in the sleep. And finally, the abnormal movements or behaviors during the sleep, which are your parasomnias or dysomnias. The first complaint is difficulty in initiating or maintaining sleep. So when we talk about difficulty in initiating or maintaining sleep, it also pans down to the sleep routine or the sleep schedule that the child is following or the parents are following. So we ask them questions about the pre-sleep activities. What is the time that the child goes to sleep? What is the environment that the child sleeps in? What are the routines that you follow? And is there any schedule that is followed by the parents? Many times the parents and the grandparents are living under the same roof, and there are regional or cultural differences as to how a new age parent wants to practice sleep compared to the grandparents who have their older ways of managing sleep disorders in children, or not sleep disorders, just sleep itself in the child age group. Second thing is the bedtime routine. Are there any bedtime routines that are followed? Is there a bedtime routine that we follow? How many of you have a bedtime routine here that you regularly follow? Raise of hands, those who have a regular bedtime routine. So it's very handful. So having a regular bedtime or a consistent bedtime routine is also very important, because you're training your mind that, okay, it's time for me to go back to sleep. And then finally, when the child wakes up in the night, what are the response of the parents to these awakenings? The second complaint that they can come with is excessive daytime sleepiness. It is important to distinguish between fatigue and sleepiness. Fatigue, as we know, it is the child feels tired or is low on energy, but the sleep duration is normal. But in sleepiness, it's difficulty in staying awake, they have accidental sleep or excessive sleep. So some of the differentials for fatigue include anemia, hypothyroidism, other medical disorders, chronic fatigue syndrome, and depression. As Dr. Rajgopal already mentioned, the international classification of sleep disorders, all of these factors can cause sleepiness, ranging from insufficient sleep to some medication effects, central disorders of hypersomnolence, and sleep-related breathing disorders. So many a times a child can just present with complaints of irritability, hyperactivity, and inattention. So always ask how well is your child sleeping at night. And the third complaint is snoring. Children who snore for less than 3 nights per week are called primary snorers or occasional snoring. But when you have a child that is snoring for more than 3 nights per week or for more than 30 minutes per night, that is there for the last 3 months, then we consider this as a concern. And this is what we label it as habitual snoring. You heard the term sleep disordered breathing in the previous talk. Sleep disordered breathing is nothing but a spectrum of symptoms. It can range from snoring and to the extreme end of the spectrum, that is obstructive sleep apnea. So all the children who snore don't have obstructive sleep apnea, and all the children who have obstructive sleep apnea do not need to have only snoring as their complaint. So this is something that you have to understand. So when they did a study, it is a population-based study, parents reported that the child always snored in only 1.5 to 6%. So this is a significant low number. The parents reported apneic events or gasping events in 0.2 to 4% of the children. Sleep disordered by breathing by varying constellations of parent-reported symptoms and questionnaire were 4 to 11%. And the overall prevalence of parent-reported snoring by any definition of the meta-analysis was 7.45%. And finally, the last complaint is movement and behavior disorder. It can range from simple benign movements to complex movements. Simple movements can be sleep starts or hypnic jerks or benign myoclonic jerks that are very common in the infancy. And then you have the complex movements or the complex behaviors that are your parasomnias or sleep-related epilepsies. So now that you have a child who has presented with you with some concerns regarding sleep, then what are the questions that you ask? First question that you ask is for how long is this child having this sleep problem? What is the duration of these problems? For us to label many of the sleep problems, sometimes the insomnia is required to be present for 3 months. Our circadian rhythm disorders, we need them to be there for 2 to 4 weeks before we label them as having an insomnia. How frequent are these episodes? For example, when we talk about narcolepsies or when we talk about parasomnias, how frequent do they occur and what is the intensity? And then we also ask about associated symptoms. Snoring in children is associated with hyperactivity in the daytime, but whereas in the adults it is more of being dull and hyposomnolent. Sleepiness can be a sign of narcolepsy, and narcolepsy type 1 can present it with just cataplexy alone. Leg movements during sleep. Are there any extremity paresthesias during the wakefulness or an urge to continuously move the legs? And finally, insomnias. Most of the insomnias are they pan out of depression or anxiety, and then we also have to take a detailed psychological evaluation. And then finally, we ask the following questions regarding the sleep schedule. First question is, what time does bedtime routine begin at? And what time is your child in bed? And what do you do to put the child to sleep? Third question is, what time do you estimate your child's fall asleep? Like, it is the not the time that the child goes to bed, it is the time that the child falls asleep after going to bed. This is what we label it as sleep latency. Fourth question is, does your child wake up during the night? If they wake up, how many times do they wake up? What is the duration of each awakening? How are you helping your child put back to sleep? Are they self-soothing and going back to sleep on their own? If yes, what is the frequency and the duration? What time does the child wake up in the next day? Does your child sleep or nap during the daytime? And if yes, what is the time and what is the duration? Because this becomes very important. Naturally, 80% of the children stop napping by the age of 3 years. The remaining 20% maximum by 5 years, they do not need to have naps. And we usually recommend them not to have their last nap before 3 p.m. or 4 p.m. because it is going to hinder the sleep time at night. And then how many hours for 24 hours does your child sleep? So this includes your daytime naps as well as nighttime sleep. If this falls in the ASM recommended duration, then we consider this as adequate. If it is without over the range or below the range, then we have to screen for sleep disorders. And finally, when you have any of all of these symptoms and you feel like this child is suffering from a sleep disorder, we prescribe them a sleep diary that the parents can log on their own. So this is how a typical sleep diary would look. This is an ASM recommended sleep diary. What you notice here are days that is there on your y-axis and the time that is there on your x-axis. Arrows are marked for the time that the child is awake in the middle of the night, and then you shade the duration of the night that they are sleeping, and then you monitor. Many of the times, the sleep diary is important when you are ruling out or when you're treating insomnias, especially your delayed sleep-wake phase disorders or your advanced sleep-wake phase disorders. So you know what time the child is going to bed. Finally, then you talk about the bedtime routine and the bedtime environment. Bedtime routine is there a routine that they follow? Preferably, we counsel the parents to have 3 to 4 low frequency activities that are of over a 30-minute duration that the child goes to sleep. Sleep environment should be consistent. It should not be like the naps are taken in a different room or in the living room and the sleep is in a different place. And what is the lighting in the room? What is the noise level? What is the temperature? Is it ambient temperature or not? Or all of these that we have to sometimes consider. So as I mentioned, in the sleep environment, you consider the location. Many a times, some of the houses are very proximal to the main road, and these noise can be hindering the sleep. The cohabitants, are there any parents in the room, or is the child sleeping alone, or is the presence of a sibling? Lights or electronics in the bedroom, or screen time before going to bed, noises, and the temperature. Now that you have all of these details, we prescribe what we call as a sleep log or sleep questionnaires and video recordings. These are of very significant importance when we are screening for a child with sleep disordered breathing. A sleep log, as I mentioned, is a 2 week. We give them to over 2 weeks where they mention the bedtime, the rise time, the time of sleep onset and awakenings, any nocturnal events like arousals, or if the child had any apneic events or snoring events. And according to the parents, what is the perceived quality of the sleep? And finally, they also shared what are the naps or if there were any. And we also consider taking the eating or feeding pattern. Are they consuming any sugary drinks? Are they consuming any caffeinated products during the daytime that could probably hinder their sleep quality? And we also talk about the degree of alertness during the day, because how well you sleep reflects on your daytime behavior and your activity. And finally, the observations regarding nocturnal events, any medications that they're taking, or any psychological stressors. We have validated questionnaires that can be completed both by the parents or the child. They are age-specific questionnaires, which are brief that I will be talking about in this session. And finally, home video recordings. Video recordings are a very typical, very crucial part of our clinical screening for sleep disordered breathing, because we are able to screen for these parasomnias, any abnormal movements. Parents bring in video recordings of their child snoring. We are able to even see apneic episodes or more grunting episodes that the child could probably have. To make this simple, for the pediatricians who are having busy practice, we can use a simplified questionnaire, what we call it as a BEARS questionnaire. B in BEAR stands for bedtime problems, E is excessive daytime in the night, R is the regularity and the duration of the sleep, and S is snoring. These are age-specific questionnaires that are available, and if you can just remember BEARS as a mnemonic, it's easy for you to ask questions in your sleep clinic. You also have some detailed questionnaires like the Pediatric Sleep Questionnaire, which is a 22-item questionnaire. This mainly screens for sleep-related breathing disorders, that is predominantly your snoring or suspected obstructive sleep apnea, and they have seem to have high sensitivities compared to your level 1 polysomnography, which is a gold standard. And finally, the home video recording. Obviously, a picture tells you, gives you one image, but a video gives you probably 1,000 images. So always encourage your parents to take videos of how the child is sleeping, and that will probably give you a lot of hints as to what you probably might be missing out on. And now that you have a presenting complaint, you have a history of presenting illness, are there any medical history or the past medical history that can be contributing to this child's current sleep? The most common problem that we see is whether the snoring is related to any other underlying comorbid condition. Many a times we see children with obstructive sleep apnea or sleep disordered breathing suffering from allergic rhinitis. They can have asthma as well. Children with craniofacial abnormalities like Down syndrome, because of their anatomical problems, can have sleep related disordered breathing. Obesity itself is a phenotype of obstructive sleep apnea. Conditions like Chiari malformations and other brainstem compressions can cause apneic events or the central sleep apneas. And then you have movement disorders, that is your ADHD, autism spectrum disorder, iron deficiency anemia that can cause restless leg sleep. And you have circadian rhythm disorders that are very common in children or adults, specifically who are having bipolar disorders, schizophrenia, and blindness. Insomnia is very common in autism spectrum disorder because of the dysfunction of the melatonin hormone or the production of melatonin itself. And children who are suffering from depression and anxiety are known to have predominantly insomnia problems. And finally, the hypersomnia, whether it's an idiopathic hypersomnia, whether it's an narcolepsy, or whether the child has undergone any underlying brainstem surgeries or tumor resections. And then you ask for any previous surgical histories like adenoidectomy and tonsillectomy. Most of the causes of obstructive sleep apnea in children are secondary to adenotonsillar hypertrophy. But whether only the adenoids were removed, only the tonsils were removed, what was the technique that was followed? Because there is always a chance of recurrence. If their parent might come to you, yeah, adenoids were removed, but why do you think the snoring is recurred? It is very important for us to consider what was the technique that was done and how long ago it was done, because Each technique has a specific amount of recurrence. Any other airway surgeries that was done, dental interventions form a crucial role when we are taking a sleep history. And rarely the neurosurgical surgeries like hypothalamic tumor resection, vagus nerve stimulators, and posterior fossa decompressions. And we know it's very well established that sleep disorders have a genetic predisposition, especially a restless leg syndrome. Parasomnias have known to have a family predisposition. There is always usually a affected family member, so always ask if there is a family history of parasomnias. And then you have a differential diagnosis for parasomnias, that is your nocturnal frontal lobe epilepsy, which tends to run in the families. Once you have a detailed exam history, then we go on to the examination. First one is your vitals. Children can be obese or underweight because of an underlying obstructive sleep apnea. It's a double-edged sword. What is the baseline respiratory rate? What is the awake saturation? And what is the BP? General appearance, we see many of the times the children falling asleep during their examination hall itself in the OPDs, whether they are having any sleep disorders that are missed out, or whether they are very hyperactive. Sometimes it is very difficult for you to get a child to sit and examine them, and whether the child is just frequently kicking around, moving their legs, gives you a lot of signs as to is there any other sleep disorders that you should probably screen. And then finally, the facial appearances gives you a sign of the child might have an underlying obstructive sleep apnea or a sleep disordered breathing. Most common are your craniofacial syndromes like Down syndrome, Pierre-Robin syndrome. There's a children with mucopolysaccharidosis and Duchenne muscular dystrophy. And then you have the typical adenoid faces that you see and the tonsillar hypertrophy that you regularly see on your clinics. So you do a detailed head, neck, and throat evaluation where you use the Malampati grade of scaling. This helps your airway team or your anesthetic team plan for the surgeries better. Your tonsillar grading is where you use the Brodsky score to label the size of the tonsils. I must say that the size of the tonsils does not correlate to the significance of your obstructive sleep apnea. You might see a child with grade 4 tonsils, but that does not mean that the child is having severe symptoms. So it does not correlate. And it's the same thing with the snoring as well. Louder the snoring does not mean the child is having severe problems. Sometimes snoring might not be picked up at all, but the child might be having severe sleep apnea. Once you have a detailed history and then you perform a general physical examination and a detailed head and neck evaluation, including dental examination, you suspect this child of having obstructive sleep apnea, then your question is, how do we proceed? Once you have a suspicion that this child could have an obstructive sleep apnea, we do something called as a polysomnography or a sleep study. This is a gold standard. And overnight level 1 polysomnography is the gold standard for detecting obstructive sleep apnea. However, there are different levels of sleep studies. That is your level 1 sleep study, level 2, level 3 sleep study, or what we call as home sleep apnea testing. A level 1 sleep study typically looks like this, where a technician is involved in the connection of the leads and they monitor the child overnight. There are almost 18 to 20 channels that are collected, including your EEG, EOG, EMG leads. You have the respiratory belts that you can see here. These are the respiratory belts that are connected, a saturation probe, a nasal cannula and a nasal thermistor that helps you pick up apneas and the hypopneas, and the EEG leads which are connected to a head box, which gives the technician as to what are the sleep stages, if there are any arousals that are occurring in the night. They also have a EMG lead that they connect, one obviously to the chin and the other one to the tibialis to pick up any periodic limb movements. So now what are their indications to perform a polysomnography? Do you perform a polysomnography in every child that is suspected to have obstructive sleep apnea? These are the indications. One, if you have a clinical assessment that is helping you suspect an OSA, you should. ENT colleagues might disagree, but pre-adenotonsillectomy, we would advise you to do polysomnography. Post-adenotonsillectomy, if the symptoms are still mild and you're suspecting residual OSA, if there is a risk of residual OSA in children with craniofacial abnormalities like Down syndrome and obesity, you have to have an underlying sleep study available. And to assess treatment response, you've done a airway surgery or you've done a dental intervention and you want to see, or you want to do a staged repair of in cases like a cleft lip or a cleft palate with retrografia, we do staged sleep studies to see what is the response to the intervention that is performed. And then finally, the titration for children who are already on non-invasive ventilation. Non-respiratory indications are when you do a polysomnography to evaluate for periodic limb movements, Restless leg syndrome and periodic limb movements are different. Do not get confused with the same. Then you do a polysomnography with a multiple sleep latency test in children with suspected narcolepsy, where we do an overnight sleep study, and in the daytime we do a sleep latency test to see what is the REM time or the sleep onset REM time in children with suspected narcolepsy. And then in children with parasomnias, if they are having obstructive sleep disordered breathing, first we rule out an OSA and then we treat the parasomnias. However, there are disadvantages with the polysomnography. One is obviously it is technically challenging. You need centers that are trained. You need technicians who are trained to perform these studies. Finally, the cost, and it is technically challenging. Now, with the advent of smartphones, everyone uses smartphones which have what we call as an actigraphy device or an accelerometer. Accelerometers or actigraphy, it is not a substitute for your polysomnography, but it helps you give you your total sleep time, your wake time, how much time you spent in deep sleep and non-deep sleep, and it will helps you at least in an arbitrary value overestimate or an underestimate your AHI values. To summarize, a targeted and detailed history and physical examination is critical in the management of children with sleep apnea or suspected sleep disorders. Polysomnography is the gold standard for the diagnosis of obstructive sleep apnea or children with sleep disordered breathing. However, in many circumstances, clinical discretion can be implemented to avoid the need for polysomnography, particularly when sleep lab resources are limited. Thank you. In our undergraduate curriculum, we do not know what questions to ask and what we can suggest to them. And finally, most of these problems do not settle on their own. So, sleep architecture in an infant is very different from how it is in an adult. When a newborn spends almost the 18 to 20 hours of its time sleeping, in the 18 hours, 50% of the time is spent in rapid eye movement stage. And as the child ages, the slow wave sleep or the stage of sleep increases. So, there's this parent who comes with a 1 week old child and says that the child does not sleep at night. Are we doing anything wrong? Do you think this is a problem or not a problem? Is this normal sleep? How many of you feel this is not normal sleep? Show of hands for those who feel it's not normal sleep. Why do you think this is normal sleep? Exactly. What age do you think the circadian rhythm is usually established at? 2 to 3 months or 4 to 6 months? Okay. So, as you rightly said, this is a normal newborn sleep. The daytime sleep is equal to the nighttime sleep. There is no day night differentiation, and it only occurs by 6 to 12 weeks, that is 3 to 4 months. So, a brief in the development of the circadian rhythm. Babies are born with very low maternally transferred melatonin. So, they do have some amount of sleep regulation that occurs, but that disappears within the first week. So, the daytime and the nighttime differentiation occurs only by 3 to 4 months, and sometimes in some children, it is normal for it to occur even by the end of 6 months. So melatonin levels, if you do levels, they stabilize by the age of 6 months. Then there's a second mother who comes with a child who's 6 months old, who says, my child is still not sleeping through the night. Is this normal sleep? All those who say it's not normal sleep, show of hands. Okay. Why do you think this is not normal sleep? Okay. Say this is a normal child, exclusively breastfed, does not have any underlying comorbidities. Is it still normal sleep? We do consider this as normal sleep. I'll tell you why. So the term sleep consolidation or sleeping through the night, it occurs only by 9 months of age in 70 to 80% of the children. So it's okay for a child not to completely sleep through the night. And also, as Dr. Bharath said, sleep regression is something that is very common in this age group, and you don't expect the child to sleep through the night. So they start having cat naps or cluster naps is what we call them, and they only by the age of 6 to 7 months or 7 to 9 months they start sleeping through the night, and it's a developmentally normal stage in their life. So if you see the development of a circadian rhythm at birth, it is a fetal circadian rhythm. That sleep is disturbed through the day and night, but by 9 to 12 months, 70 to 80% of the infants sleep mostly at night. So the same thing is a normal sleep development in a child. As I mentioned, 70 to 80% of the children by the age of 3 years cease to have a nap. It's many of the children by the ages of 5 years stop napping. So it is physiological for them, it is normal for them to take these naps, whether it's one nap or two naps. We do consider this as a part of their normal sleep routine. And finally, they have another child. Is it normal that a toddler doesn't seem to need naps? She sleeps for 10 hours each night, but won't stop playing at nap time no matter what we do. Is this normal sleep or no? Not normal. How many of you say this is normal sleep? Okay, so majority of you feel this is normal sleep. I would disagree with this. So this is not normal sleep. It is important for a child to take nap. A 10-month-old is sleeping only for 10 hours, is obviously sleeping less. When you calculate the sleep duration, we calculate the nighttime sleep as well as the daytime sleep. An infant, it's normal for them to sleep twice a day. It usually occurs in the morning between 8:30 to 10:30, and the second one maybe between 2:30 and 4:30. Toddlers, they take one single nap that is probably in the afternoon, that is of 1.5 to 3 hours. And preschoolers, they cease to taking naps at 3 years or 5 years, as I already mentioned. Now, this is a case. An 18-month-old Arjun's mother comes with the following complaints. Arjun wakes up multiple times in the night, at least 5 to 6 times. He sleeps between 10 p.m. to 6 a.m. That means he's having a nighttime sleep duration of 8 hours. The mother has to breastfeed the child to put him to sleep. He cries excessively if the mom doesn't feed him and he does not sleep. He currently sleeps on the same bed as the mom and is able to latch on to her on his own if she's sleepy. He feeds and goes back to sleep. So the mother asks, "Is this okay, doctor? How long is this going to go on? Is this normal sleep?" So this is an 18-month-old who's waking up multiple times in the night, who requires to be fed every time the child goes back to sleep, is not having any comorbidities. Do you consider this normal or not normal? Show of hands those who consider this as a normal sleep. Okay. So let's answer each of the following questions. Your first question should be, is there a sleep problem at all? First, you have to ask the parent, is their perception, do they consider this a problem at all? For an 18-month-old, say the mom is working, if she has to wake up every time that the child has to sleep, that is almost 5 to 6 times per night. Obviously, the mother's sleep or the caregiver's sleep is also going to get disturbed. Is the duration of sleep normal for his age? He's sleeping between 10 p.m. to 6 a.m. and then he says he's taking one or two naps. Do you still feel 10 hours of sleep is adequate for his age? So if you look at the lower limit of normal, we do consider it as okay, but the child should be sleeping anywhere between 10 to 12 hours at this specific age. Are the multiple awakenings during this night acceptable? I would say no. It is normal for a sleep consultation should occur by the age of 6 to 9 months, and for an 18-month-old to have multiple night awakenings, it is a problem. So it is not normal for them to have multiple awakenings in the night. So every time the child wakes up, what does the mother do? Breastfeeds. So now the next question is the breastfeeding or rocking or any of these associations contributing to the sleep issues? This is something that we probably have to ask. Does the mother think this is a problem? Do we as pediatricians consider this as a problem? This is where our learning comes from. Is there any medical issues that there is occurring? Should the mom accept her fate as this is normal for all children and then move on and deal with it? We will answer these questions in the next slides. So first, is there a sleep problem at all? Yes. Do not rubbish her complaints saying that this is not a sleep problem at all. You should probably take a more detailed history saying yes. Because we have noticed that the mothers who are sleep deprived are many times labeled as having postpartum depression or postpartum psychosis, and their outcomes are pretty poor. So a baby not sleeping through the night, for an 18-month-old who's not sleeping through the night, it is definitely a concern and the child is not sleeping well. Is the duration normal for this age? Child is 18 months, sleeping for a total of 10 hours. So if you look at the American Academy of Sleep Medicine guidelines, a child who's 18 months should sleep anywhere between 11 to 14 hours, that is including naps. So here we do not consider that the time the child was awake in the middle of the night. This is what we call as wake after sleep onset or VASO. Every time that the child is awake, say 10 minutes or 15 minutes, the child is awake, and this happens for 5 to 6 times in the night. That's equivalent to 1 hour of the child being awake. We do not calculate this in the total sleep duration. That means the child is probably not sleeping well. Next question is, are the multiple awakenings during this night acceptable for this age? Some of you said yes, some of you said no. So for this, you should understand the stages of sleep, what are self-soothing skills, and what is sleeping through the night mean. So if you look at the sleep architecture, you have stages of wake and non-REM sleep and REM sleep. It is physiologically normal for us to have arousals during the REM sleep. We do have arousals, but we do not realize it because we just tend to go back to sleep immediately. It is also not about the quality of sleep, but it is about the quantity of sleep. Arousals are physiologically normal and it occurs predominantly in the REM stage of sleep. And children who are not able to go back to sleep or the non self soothers are the ones who develop these insomnia of childhood. Infants are known to have, like I said, arousals during the REM sleep. These arousals are minuscule. It is not awakenings. An arousal and an awakening is very different. Arousals is something that you pick up on an EEG. Awakening is something that obviously is you see it out loud. Parents may hear whimpering or mild sounds during these arousals, and it has to be differentiated from the baby fully waking up. And then finally, talking about self soothing. Self soothing is the skill that the baby possesses to go back to sleep on their own without having the need for assistance. Self soothing is something that most children do not possess naturally, but then you do have chronotypes of self soothers versus non self soothers. And it is the self soothers who have obviously better sleep architectures, they sleep well, they grow well, and obviously their performances are known to be better. So self-soothing is nothing but the ability of a baby to put him or herself to sleep on their own without any assistance. And a child who's not able to do this is obviously going to be labeled as having an insomnia. So the development of a self-soothing, it is a developmental milestones. Baby should be able to go back to sleep from an arousal during REM sleep, which is natural. And in long term, it helps in consolidation of sleep. And then you ask, are there any medical issues that could be contributing to this poor sleep? What are the medical history that you would take when you ask a child whether they're sleeping well at night or not? What are the concerns that can occur in the night? Can you name a few? I will start off with maybe gastroesophageal reflux. GER can contribute to poor sleep. Anything else? Bite reactions. Okay. Pain. Okay. No lack of ambient temperature, sound, noise. Enuresis in an infant, it is common that they will not probably have bowel control or bladder control at 18 months of age. Secondary enuresis is something that we're probably more worried about. Primary enuresis isn't. Worm infestations, we're worried about colics, rhinitis, atopic dermatitis or eczemas, food allergies and sensitization, and any snoring or sleep disordered breathing that the child is having. So once we feel like the child is going to have these concerns, then we take a detailed sleep history. We have something called as the brief infant sleep questionnaire that gives you it's a multiple choice question where the parent is allowed to fill out the questions. And then we also have child sleep habit questionnaire that is slightly for children more than 3 years of age. Now you establish that this child is having a sleep problem and the parent is in denial, but you obviously want to log. Then you advise them to maintain a sleep log over 2 weeks. If not, then we also do the bears questionnaire that I already mentioned in my last session. And despite all of this, if you feel like the child is having some sleep issues, majority of the time, most of the complaints are one, the child presents with multiple awakenings at night. So if you look at the definition of insomnia, it is delay in initiating sleep or delay in sustaining, difficulty in sustaining sleep. So it is either the child is taking a longer time to go back to sleep or the child is waking up multiple times and finding it difficult to go back to sleep. Second most common thing is resistance to go to bed. The child asks for a parental presence. The child asks for one more story. The child says, "No, I don't want the lights to be switched on. Can I watch TV for 15 more minutes?" All of this is bedtime stalling. It could be a reason. It could be a feature of sleep anxiety or bedtime anxiety. Then delayed sleep time with play. This is very common. Most of the time, we see something called as a social jet lag. Children tend to sleep on time on the weekdays when they have school, but when it comes to the weekends, they tend to delay their sleep. So the social jet lag can contribute to many of these factors. There's a lack of daytime naps. Some parents believe that tiring the child. One of our colleagues just asked, "Is tiring my child going to help them fall asleep?" It is not. You're overstimulating the child, and obviously the brain activity is going to be higher, and the child is obviously going to find it more difficult to go back to sleep. So all of those who are under the conception that I'll tire the child, let them run around, play around, and get tired, they're not going to go back to sleep immediately. And that is where we talk about having a bedtime routine. It should be a low frequency, self soothing activities that help the child calm down and prepare for bed. And then if the child is not sleeping well in the night, then obviously the child is having difficulty waking up in the morning. Child will probably want to sleep for half an hour longer, 1 hour earlier. You have difficulty in waking up, or probably the child goes to use the washroom and the child is caught sleeping on the toilet seat because the child is probably not slept well at night. And then last is the bedtime fears or the sleep terrors that the child has. And it is common for a child who's of between 3 to 5 years to have anxiety. It is very common for them to also have nightmares. And when they have a nightmare the previous night, then the anxiety level on the next night increases, which delays them to going to bed. So for all of these children who are having these sleep issues, is what we do as sleep coaching or training. So we assist the parents. So this problem is not with the child. So in what we call as behavioral insomnia of childhood, the problem is not with the child. We've ruled out the child is not having any comorbidities. Child is not having any underlying obstructive sleep apnea. And now this is a habit that we as parents have inculcated in our children, and they think that this is normal. For example, in this boy Arjun, he thinks only breastfeeding or feeding him is going to help him go back to sleep. It is something that the parents have trained. See, at 18 months of life, the child does not require to be fed at night. Child after 8 months or 9 months of age can sleep through the night for a period of 6 hours without having any feeds. You've ruled out the child is not having any comorbidities. So you're training this boy to think that every time you wake up, I'm going to feed you. And this becomes a cycle. And every time the child wakes up, you're going to end up feeding the child. And suddenly you decide, no, doctor, I don't want to feed anymore. That is why my child is waking up and crying. Now, then this comes down to the temperament of the child and the parental expectations as to how we want to do the sleep coaching. It's not that one size fits all. We have to see what is the parental expectations, the family expectations, and the temperament of the child every time we choose a child to do sleep coaching. So you have to take in a detailed history. It obviously does take time. It takes out at least 20 to 30 minutes of each case when he's seen a sleep clinic to do sleep coaching. But obviously the results are rewarding. So based on what the temperament is, we have different strategies. But before we have a strategy, it is important for us to do some primary steps. One is obviously set a fixed bedtime. Many of the times we don't have set bedtimes. We have some children who are sleeping at 10:30, 11:30, 12 a.m., in fact, even 2 a.m. because Indian parents obviously wind down late, they come back from work late, they have dinners late, and they think it's normal for their child also to sleep late. So, first, setting a bedtime is important. When you set a bedtime, you work prospectively and decide, okay, my child requires 10 hours of sleep or 8 hours of sleep, so I'm going to wake them at 6 a.m. So, when you put them to sleep at 8 p.m. and they're allowed to sleep till 6 a.m., that means they're easily getting 10 hours of sleep at night. So, setting a bedtime is very important. Establishing a bedtime routine, as I said, becomes very important. It should be very simple activities. It should be consistent, simple activities. For example, even if it is just taking the child to bed, before that, you start talking, okay, it's time to go to bed. You're telling the child, okay, it's time to go to bed. You start using these words so the baby is getting trained to think, okay, it's time for me to go to bed. You change the clothes, you brush the teeth, you listen to some music, you dim the lights. You do this consistently, and then the baby is going to obviously start thinking, okay, this is time for me to wind down. You do not engage in this child with any of these activities. Remember that even if it is a negative reinforcement or a positive reinforcement, attention is attention. Even if you're going to yell at the child, it is still you're giving the child attention. You have to ignore all child's needs. They'll say, no, mama, I want 1 more hour. I want to sleep for half an hour longer. Can you stay in bed? You have to not give in to this children's needs. If you give in, they know obviously that one of the parents is weak, and they're going to go to them saying they are going to give in. So consistency becomes a very, very important part of sleep coaching. Although the third point is difficulty in the Indian scenario, reducing co-sleeping, because sleep coaching strategies are obviously more beneficial when the child is sleeping separately. There is a concept of what we call as co-bedding. Does anyone know what is the difference between co-sleeping and co-bedding? Co-sleeping is in the same room. Co-bedding is same room, different beds. Or it's the same room, same bed. Co-sleeping is the same bed. Co-bedding is in the same room but different beds, or you have a crib. Co-bedding is something that we can accept. At least religious or our customs expect our children to be on the same bed as their parents. We can expect some co-bedding. And then obviously we have to keep in safe sleep practices in our mind. So to set a fixed bedtime routine, I already spoke about this. And then there are benefit studies that have showed the benefits of having a bedtime fixed bedtime, and then you establish a sleep routine. So you can put up charts in the child's room that you can tick every time the child has to start a bedtime routine, so the child is involved. It's positive reinforcement. So you start with having a bath, put the pajamas on, you brush the teeth, go to the toilet, read a book, and then finally it is sleep time. So the routine should be the same on all days. And this helps the child unwind and understand the concept of sleep time. And finally, reduction of co-sleeping. Ideally for Indian parents, crib sleeping in the same room as the parents, which is called as co-bedding. And now finally, coming to the crux of this talk is the behavioral insomnia of childhood. It refers to the bedtime problems and night awakenings in young children. Do we agree that Arjun has behavioral insomnia of childhood? Yes. So in behavioral insomnia of childhood, either the child has difficulty in falling asleep, or if the child wakes up, the child has difficulty sustaining or going back to sleep on their own. Most of these problems do not resolve on their own. And when we identify these problems early, some parents may ask, how early can I start sleep coaching? There is no right time, there is no wrong time. Many of the time, antenatal counseling of what to expect during the sleep of the child is something that we start off. Even if it's a 3 month old, obviously they will have some physiological changes, but we need to help them understand what is the anticipatory guidances they need to follow when it comes to the child's sleep activities. So you have two types of behavioral insomnia of childhood. One is the sleep onset association type, and second is the limit setting type. So sleep onset association is the child is associating a specific activity for sleep. Here you can have associations, you can have what we call as positive association and negative association. In the case of Arjun, breastfeeding is a negative association. Basic strategy that we say is, do not do the things that you don't want to keep doing. Say now, can the mother keep breastfeeding Arjun for the age of 2 to 3 years to help him go to sleep? No. Can we keep rocking the child to go to sleep? No. Can we keep driving the child around to go to sleep? No. Do simple things. We expect patting, shushing, and holding. These are the only things that we expect the parents to do every time the child awakes. This should be the same that they follow when they're putting the child to sleep, and this should be the same activity that they follow when the child is also awakening in the middle of the night. Although when we start with sleep coaching, we obviously, there are going to be difficulties putting the child to sleep. The child is dependent on breastfeeding, but the awakenings at least we can address by just doing the positive associations. And then you have the limit setting type. Here the child is setting the limits, saying, I want half an hour more, can you sleep with me for half an hour, can I watch TV for a little longer. All of these limits are set by the child themselves. And when both of them exist, then we call this as a combined type. So as I mentioned, behavioral insomnia of sleep onset association, falling asleep is an extended process that requires special conditions. Sleep onset associations are highly problematic or demanding. In their absence of sleep onset, it is significantly delayed, and night awakenings require interventions. So here child X requires to fall asleep and then needs X to fall back asleep. Here example, it is rocking, watching TV, or a parental presence. And it is sometimes they consider this as a normal to wake up 2 to 6 times per night. It is normal for us to wake up 2 to 6 times per night, but going back to sleep or self-soothing is a skill that many of the children lack. So you have signalers versus self-soothers. Signalers are the ones, in case of Arjun, who cries out loud saying, I want milk, and the mother ends up feeding. Self-soothers are the ones who go back to sleep on their own. And then the second type is the limit setting type. The child has difficulty in initiating or maintaining sleep. The child stalls bedtime or refuses to go to bedtime at an appropriate time. And then there's an insufficient limit setting to establish this appropriate sleep behavior. And then you have the combined type that I already mentioned. So when you have to manage these children, it depends upon, like I said, what are the parental expectations, what is the child's temperament, and what are the goals that they want to set. So when we take in a sleep history, we ask the parents, what are the goals that you want? Some parents are very clear, no, I don't want my child to cry at all. I cannot stand my child crying. I want my child to be with me, and I want to be with the child. And there are some parents who are okay with the child crying for a specific duration of time, and then we give them that. So based on their expectations, there are strategies. So you have two types of strategies. So it's basically called as extinction strategies. Extinction is you give them time, like you wait it out. You have something called as a standardized extinction, and what you have called as a graduated extinction. Standardized extinction is a little more Western, because obviously the child is sleeping in a different room. Standardized extinction is where the parents are allowing the child to cry. It's the allowed to cry method. Tonight, the child might cry for an hour. Tomorrow, the child might cry for 40 minutes. But when the child realizes, no, I'm not going to get any help and I have to go back to sleep on my own, these have shown to be faster to self soothe. In a period of 1 week, the child goes back to sleep on their own. But now, obviously, in the Indian scenario, we are sleeping with the children in the same room. We cannot use the standardized extinction. Then we speak about what we call as a graduated extinction. In graduated extinction, we set a time. We set a time that the parent will not engage with the child at all. So, say Arjun woke up in the middle of the night. We have to ask questions: how long are they allowing Arjun to cry? How long are they allowing Arjun to self-soothe? If you ask, many of the times, either the father is very irritated, like, no, feed the child, let him go back to sleep. Or the mother does not want the child to cry, they immediately feed the child and then put him back to sleep. You just need to give them some time. If a child parent does not want the child to cry, we start with smaller durations. If a child is slightly parent is having a better temperament, we start with 15 minutes. So we use something called as a stop clock method. At night, obviously 15 minutes might seem like a long time, it might feel like an hour together. 15 minutes, we set a stop clock saying, allow the child to cry. You do not engage with the child, you do not allow the child to do anything, you do not switch on the lights, but you just allow the child to cry. 15 minutes have gone past. The next 15 minutes, you're only going to do positive associations. Either you pat the child, hold the child, or shush. You're not going to get up from your original sleeping position. You're not going to engage with the child. You're not going to talk to the child. 15 minutes, half an hour have passed. Despite this, the child is not settled, then you can feed. You do this for 2 to 3 days. Now the child is going to think, okay, it's 15 minutes. I will wait for 15 minutes. But then you increase the time to 20 minutes or 25 minutes. Slowly, slowly, you increase the time of where you do not intervene. The child is obviously going to get trained thinking, okay, I am not going to get help. But for all of these to be successful, the only key message is to be consistent. If you're going to give in, see, obviously the kid is smart, the child is going to know that one of these two are going to give in. But if both the parents are consistent with their sleep coaching strategies and they know that they're not going to give in, come what may, it should not be like a jackpot. Today I cried for half an hour. Okay, let me try for 40 minutes. So one of them is going to give in. Parental expectations should be set. You are not going to give in for 30 minutes. You are not going to become a bad parent by allowing a child to cry. Some children obviously might cry and end up vomiting also, but it is not like they're going to be in any form of danger. So the key principle of any sleep coaching strategy is consistency. I might give a strategy today and the parents might start following it from tomorrow. Tomorrow is going to be the worst. We've had many of them saying, what kind of a doctor are you? Why are you giving these things? It's going to harm our child. But once you notice that there is going to be a consistency in what they do, the child is obviously going to feel better. And then once you've done this for 2 to 3 weeks, see, graduated extinction compared to standardized extinction is going to take longer because you're starting with shorter durations of time. It might take 4 weeks, it might take 6 weeks. But at the end of 4 to 6 weeks, you can also expect something called as an extinction burst. All of these strategies that you've done might take a reverse. The child might start having an awakening again. But it is very important for you to tell your parent, continue to be consistent. Majority of the times our counseling is only being reinforcing these same measures in our parents, saying you're doing a good job. They just need to hear it from us saying that they're doing a good job. And we should be able to pick up any soft signs or any warning signs that are probably apart from the behavioral insomnia of childhood. So here you should have, like I mentioned, you should have consistent positive routines. That is a bedtime routine. You should allow the child to fall asleep independently or sleep on their own, and it should be a globalized approach. So you have standard extinction that I spoke about, and you have the graduated extinction. It is better tolerated in Indian children, but it takes longer time compared to standardized extinction. And then you have something called as a fading of the parental presence. Initially, the parent starts at the bedside of the child with the chair. Every night, the parent moves away. It's called a chair method, where the parent is increasing the distance between the bed and the child and the chair, and slowly transitions out of the bedroom. Or in some cases, you can tell, I'm going to come back in 15 minutes, go to sleep. And slowly, slowly, you increase the duration that you don't return. In such cases, you can do anticipated awakenings, or you can go back to the child at an increasing duration. And then night awakenings, you have to do this for all night awakenings, including the wake times, and you have to consider what is normal. And then, like I mentioned, in limit setting, it is a positive reinforcement. It should be used for desired targeted behaviors. It should be rewarding and immediate. You can give the token award system saying, okay, you slept well last night continuously, you give them a star. The child is obviously going to have this positive reinforcement. Then the parents have to have, you do this only when the parents have continued not to travel anywhere, or they're not in their in-laws place, they're in the place that they want to sleep. You can obviously install these consistent sleep strategies, and the parent should obviously ignore negative and unwanted behaviors. So when you're doing sleep coaching, I have just a couple of slides left. Common obstacles that are, one is an inconsistent parent limit setting. That is a big obstacle, and this leads to failure. We have parental disagreement as to how to handle these bedtime problems, and any other children at home becomes challenging. The child does not stay in the crib or bed. Obviously, the child has figured out how to get out of the bed, and there are treatment difficulties due to time and energy required. So, to summarize, the quality and quantity of infant sleep is important for growth, development, memory, and attention, as we have already established. Infants should sleep through the night by the age of 1 year. You need to eliminate sleep props or the presence of negative sleep associations. Rule out comorbidities like gastroesophageal reflux, obstructive sleep apnea, and allergic rhinitis. Introduce sleep coaching as early as possible to mothers to help them sleep well too. And follow guidelines for sleep environment for infants to prevent SIDS. So these are some of the anticipatory guidances that we tell the parents to follow. That we discuss the sleep at the first baby visit. At 2 months, we encourage them to start putting the infant to bed when they're drowsy. So when they're putting the child to bed, when they're carrying the child and they're putting the child to bed, you need to identify at the time where the child is just about to go to sleep, transition from wake to sleep, and then you put them onto the bed and tap. When you're going to put them to the when you're going to allow them to nap on your shoulders or on your arm, they've understood that this is the place for me to sleep. But when you identify that this is a point where they're drowsy, and then you shift them onto the crib or the place they should sleep and tap or pat, they will start slowly realizing that this is where I need to go to bed. And then previously a great sleeper may develop transitory problems, as what we call as sleep regression. Sleeping through the night occurs by 9 months of age, and avoidance of parental reinforcement like attention, rocking, night feedings often prevents a small temporary problem from becoming a large and chronic one. Thank you.
Thank you to the team for inviting me for today's talk. How many of you are still awake? Raise your hands if you're awake. Okay. So, disclaimer, I talk really fast. Okay. So, if you all want to keep up, you'll have to stay wide awake and ask me questions after that. So, this is a very, very important topic that we need to speak about, sleep disorder breathing and obstructive sleep apnea, because this is something that you're going to encounter as pediatricians in day-to-day practice, right? Can someone tell me what's the difference between sleep disorder breathing and obstructive sleep apnea? I'm going to keep asking questions primarily because I'm not going to give you Q&A session later. So let me ask questions. So somebody answer. What is the difference between this term sleep disorder breathing and obstructive sleep apnea? Are they the same or are they different? How many of you think it's the same? Does anyone think it's a different terminology? Yeah, sure. What do you think is the difference? Go ahead. So you think it's early stage of obstructive sleep apnea? Good answer. Anybody else? Okay, how do you define whether it's obstructed or not? Very good answer as well, to say whether it's really obstructed or not. Anyone else before I go into? Okay, differentiates between sleep disorder. Good. So I think a lot of your answers are quite valid, but I'll try to explain it to you in a much more detailed manner. So through our flow, we'll be going through a spectrum of sleep disorder breathing. What exactly do we mean by this word? How does etiopathogenesis occur? Diagnosis, treatment. So let's start with the spectrum, right? So the terminology, again, bringing about this concept of sleep disorder breathing, the word, why are we as pulmonologists talking about sleep? Why is sleep coming into the domain of pulmonology is because a lot of sleep issues are very closely related to your breathing, right? Why do we have an ENT doctor here? Why do we have pulmonologists here? It's all because this entire airway passage, the passage is the one which results in sleep disorders or sleep abnormalities, right? So the concept came on saying sleep and breathing are closely related, and the word came as sleep disordered breathing, or what we term as SDB. Now, SDB can be a wide spectrum, right? So that is where the spectrum comes into. The first important part of the spectrum is snoring. We start with snoring, and then the other end of the spectrum is obstructive sleep apnea, right? So remember, we start the spectrum with snoring, and the other end of the spectrum is OSA. And all of this comes under this entire bracket of what we call as sleep disorder breathing. So when you go back to your clinical practice, you can't write the diagnosis as OSA. You need to write the diagnosis actually as sleep disordered breathing. You do not know whether it's just simple snoring or whether it's gone into OSA. We do not know. So this term I want you to take back home and learn this term, so that when you write the diagnosis, you actually, in clinical practice, you write it as sleep disorder breathing. After you do a sleep study or you do a diagnostic test, that is when you establish that it is obstructive sleep apnea. So in my clinical practice, that's what I write. I write child with sleep disorder breathing, suspected OSA for evaluation or ruling out of OSA, right? So these two words have to be differentiated. Snoring, as we know, is a manifestation of the vibrations of oropharyngeal soft tissue when someone attempts to breathe against an increased airway resistance. When do we say it is habitual snoring? When do you need to find out whether this snoring is abnormal or normal? Is a term, the second word I want you to take back, called habitual snoring. The definition is habitual snoring is snoring for 3 or more nights in a week. Why is this important? You all know that when a child has URI, the child is going to snore. When the child has viral infections, the child has upper airway obstructions, for some short durations, there will be snoring, right? But you need to ask them, is this snoring occurring for more than 3 nights in a week, consistently for a month or so? That is when you label this as habitual snoring, and that is when we'll go ahead with further evaluation. Is this clear? At least for you to know when to evaluate snoring or not evaluate snoring. Snoring is not something you need to ignore. Snoring, as we know, is one of the symptoms of OSA. Snoring can be associated with neurocognitive and neurobehavioral outcomes in children. Now, why I'm asking you this is, latest study has shown that snoring, even in the absence of OSA, has shown to have neurocognitive outcomes. This is a very landmark study which has come up lately, because what we always used to say, we used to differentiate something called primary snoring versus OSA. What is primary snoring? It is snoring but not reached the level of OSA. Like one of our doctors said, is it causing hypoxia? Is it not causing? If there is snoring not causing any of this, we used to say it does not have neurocognitive outcomes. Now the latest study has shown just simple snoring and upper airway resistance can have neurocognitive outcomes as well. Then came what we call as obstructive sleep disorder breathing, which is an entire spectrum, and then it goes to develop OSA. Now, how much is the prevalence of OSA? It has been shown that nearly 1.2 to 5.7% children have actually obstructive sleep apnea. 10% to 30% of children have sleep disorder breathing. That means in your OPD, at least 1 out of 10 children will have sleep disordered breathing, right? So if you take your Bayes questionnaire and ask how many of you have snoring, you'll be surprised that 1 to 3 children out of 10 children will say they have snoring. What is the cause of snoring? Whether it's primary snoring, habitual snoring, that is secondary. But just to say sleep disorder breathing, 30%. Out of that, you go into further evaluation, 10% will have primary snoring. And then you go into further evaluation, 3% will have obstructive sleep apnea. So even if I say 3% obstructive sleep apnea, how much OP do each of you all see in a day, approximately? Average 40 to 50? Yeah, so let's say around 30 patients. Let's say that's the lowest number that you see. 30 patients you see in a day, right? Out of that, you're going to say that 10%, that is 3 out of these, most likely have sleep disorder breathing and OSA, which is very, very high, right? And we need to take the history for these children. So this is the entire spectrum. We start with what we call as habitual snoring or primary snoring. What was the definition of habitual snoring that I told you? More than 3 nights in a week, consistently for a month, right? So then you say it is habitual snoring. But when I say primary snoring, that means it's not gone into OSA yet. Then the second end of the spectrum comes into what we call as UARS, or upper airway resistance syndrome. Then we have something called obstructive hypoventilation. And then we have a condition called obstructive sleep apnea. So your take home message from this slide is OSA and sleep disorder breathing are not the same. Is that clear? So sleep disorder breathing involves all of this. It could be just snoring, it could be just OSA, it could be hypoventilation, it could be UIRS. How do I differentiate between all of these? Is only by doing a sleep study. So the clinical diagnosis is sleep disorder breathing, and your diagnosis after investigation is any of these conditions. So what is primary snoring? So if you look at the first section, primary snoring is just primary snoring is just snoring for more than 3 times in a week, but you don't have apneas, hypopneas, no desaturation. Noisy breathing is there, but there are no arousals. The child is not waking up multiple times in the night. It is only a noisy breathing which is there more than 3 times in a week. We call this as primary snoring. Now, the second entity, UIRS, we don't diagnose much in pediatric age group, but it includes arousal, fragmentation. The sleep is fragmented multiple times, and there is noisy breathing. The last one I want you to see is when we call it as OSA, when there is noisy breathing, there is hypoxia, there is arousal, and there's absence of nasal flow, which is all detected on a sleep study to label this as OSA. The question still arises, is this relevant for you as a pediatrician or not? Do you need to know about this? Yes or no? Why? I gave you the answer already. Why? The OSA spectrum is how much? What is the percentage of OSA that you're going to see? 3%. What is the percentage of sleep disorder breathing? 10%. So that spectrum you're going to see is 10%. 3% is going to be OSA. So the prevalence is not low. So we did school studies, and it's shown that nearly 1 to 5% say always snoring, 3 to 15% say often snoring, occasional snoring, etc. But take home the message that yes, it is very, very common. What is the pathophysiology? I think if I ask most pediatricians what is the cause for snoring or obstructive sleep apnea, all of you will say adenoids, right? And again, at the end of this talk, you have to take home that message that adenoids may be the commonest cause, but it is not the primary cause or the only cause, right? Obstructive sleep apnea is a very complex disorder. It is a heterogeneous cause. It involves, what does obstructive sleep apnea means? There is an obstruction anywhere between the nostrils till the trachea, upper airway, right? So anywhere in your upper airway, there is an obstruction. It doesn't have to be only the adenoids, right? Even a DNS or a deviated nasal septum can cause obstructive sleep apnea. Even laryngomalacia, severe laryngomalacia is obstruction. So that also can cause obstructive sleep apnea, right? Because any obstruction during sleep gets more aggravated, right? So the second take home message that you need to take home is that it's a complex condition. It is not always, don't just presume it is always adenoidal hypertrophy. We need to come to the conclusion it is adenoidal hypertrophy after investigating it. But OSA can involve obstruction anywhere from your nostrils up to the level of your larynx and trachea, right? It also is not only an anatomical obstruction. We always presume that it's only an anatomical obstruction. There's something anatomically there, you remove that and the OSA is going to get cured, which is also not true. There can be a pathophysiological change in the neuromuscular tone. Now, this is where your adult OSA and pediatric OSA is slightly different. In adults, it's mainly a collapse of the pharyngeal musculature, which ends up causing this OSA. But it does not mean it doesn't happen in children. It can still happen in children as well, right? So there's a new theory which has come, a new theory which has been called as an inflammatory theory of OSA. What do you mean by inflammatory theory of OSA? Before we used to say OSA is only an obstructive disorder. You remove the adenoids, everything is gone, right? We are seeing nearly 30% of children coming back with OSA even after adenoidal removal. And in these children is where they started finding out that is OSA an inflammatory condition. So we understand that there may be an inflammation in the airway, and this airway inflammation causes the pharyngeal musculature to collapse, okay? So anatomical, yes, we're talking about anatomical narrowing due to any form of obstruction or the collapsibility. Can there be a chronic inflammation of the soft tissue, reducing the diameter and causing more collapsibility, or deposition of fat in the upper airway and that causing again a obstruction? There can other anatomical obstructions can occur when your craniofacial dysmorphism is there. So another take home message is every syndromic child will have an upper airway anatomy which is abnormal. Their upper airway anatomy is not going to be like a regular child's anatomy, right? So any child you see with genetic syndrome, right, from Down syndrome, Prader-Willi, mucopolysaccharidosis, take it whatever syndrome that you're going to see, there's a high chance that they will have OSA, right? So when I take the take-home message there is, if I see a child with any genetic syndrome, evaluate for sleep disorder breathing. They will inevitably have it. So we talk about why these craniofacial dysmorphisms can cause obstructed airways. It can be because of a crowded oropharynx. It can be because of micrognathia, macroglossias, mid-face hypoplasias, cleft palate, glossoptosis. Many of these can cause the obstruction. In Down syndrome, it can be also adenoids and tonsils, dental issues, macroglossia, flat face, hypotonia, multiple factors. But what you need to understand is, in the special population, OSA is nearly 80 to 100%. In a regular population, I told you it's 3% to 10%. In a syndromic child, it is 80 to 100%, which means if you see a child with Down syndrome, nearly 100% of children with Down syndrome will develop OSA. By what age will they develop it? If I say Down syndrome, the most commonest syndrome you see is what? Down syndrome, right? So by what age do they develop OSA? Any random guess? 5 years, 6 years, 6 months, okay? Isn't that too early for OSA? Because you said adenoids are the most common cause, right? But adenoids are not going to be there at 6 months, 7 months. Any age. Okay. So why I'm telling you this is there are a lot of guidelines released about this already. It's just that we're not aware of these guidelines. So the American Academy of Pediatrics says that all children with Down syndrome must undergo a sleep study by the age of 4 years, right? It is an established guideline already. But how many children of Down syndrome do we see? And how many children of Down syndrome are we doing sleep studies for? So they say they develop OSA by the age of 4 years for sure, according to their studies, right? 100% of them develop OSA by the age of 4 years. So you need to be doing sleep studies in these much, much earlier, even if they don't have the symptoms of it, right? So going on to the factors which can contribute to these obstructive sleep apnea features, right? So one is you'll see adenotonsillar hypertrophy. Now the question is, the adenoids and tonsils are both contributing to this anatomical obstruction. But I told you another point. Can it also be inflammation of these adenoids and tonsils, which not only are anatomically closing it, but causing inflammation of the underlying pharyngeal musculature, and that also collapsing and therefore adding to your obstructive sleep apnea. So when you remove these adenoids and tonsils, not only are you removing an anatomical obstruction, you're also removing a source of inflammation, which is contributing to obstructive sleep apnea. But remember, there can be multiple anatomical factors right from the nose up to the larynx. All of these can cause your obstruction. And most important thing which can cause obstruction for us is obesity, right? We all know that obesity and OSA go hand in hand with each other, right? What causes what? Let me ask you a question. Does obesity cause OSA or OSA cause obesity? How many of you all can say obesity causes OSA? Raise of hands. Do you think OSA is more common in obese people? Yes, that is a known factor. Why do you think that is so? One is because of fat deposition, right? There'll be fat deposition in the neck itself, which causes obesity and which causes obstructive sleep apnea. Can obstructive sleep apnea cause obesity? How many of you all think say yes? How do you think it can cause obesity? Restricts their physical activity one way. Yes. Anything else? Lot of sleep. Okay. So stress factors cause more obesity. Okay. Sorry. Which hormone changes? Cortisol, not related to obesity as much as renin and leptin pathway. Okay. So what has been shown is even your leptin pathway gets completely altered in obstructive sleep apnea. And having obstructive sleep apnea makes these children actually eat more, makes these children not be able to lose weight, right? So this is an again concept which when you see obese children, what do? First thing is you start advising on making them lose weight, right? You tell them, listen, these are, you have to go for diet control, you have to go for exercise. And what do the parents tell you? We're doing everything and still the weight is not coming down, right? And then you end up getting stuck. You'll say you're not doing enough, you're not giving proper diet control, and the parents are helpless because they're actually doing something. They're trying their best to make the weight come down. Don't you face this as a common situation in obesity? Yeah. What is the problem there is you're not forgetting that this child has OSA, and that OSA is actually causing him to not lose weight. And because he's not losing weight, the OSA is becoming worse. And because the OSA is becoming worse, again he's becoming obese. So they get stuck in this vicious cycle. So another important educational factor that you need to tell even endocrinologists and people who are dealing with obese children is you can't just treat only obesity without treating OSA. So it is found that nearly 50% to 60% of children with obesity will have OSA. So one more point you need to go home today and say, if I see an obese child, we will also evaluate for OSA. We will of course advise dietary measures, we'll advise exercise, everything. But I know it is not going to completely help till I treat the OSA also. Once the OSA gets treated, obesity comes down. And as obesity starts coming down, OSA will come down. And eventually both will work and the child will develop a good body physique. Is that a good take-home point as well? Right. And other condition where we see OSA very commonly is allergic rhinitis, right? Now, allergic rhinitis is extremely common in our clinical practice. Here, what happens? You have mucosal edema, you develop an increased nasal resistance, and indirectly it causes obstruction. The obstruction need not happen only at the turbinates. It can happen at the inferior turbinates, can happen at the adenoid level, etc. So again here, management of allergic rhinitis can also help in bringing down your obstructive sleep apnea role in these children. So what are the common symptoms? So these are the different causes which can cause obstructive sleep apnea. I spoke about your simple adenoidal hypertrophy. We spoke about genetic syndromes. We spoke about allergic rhinitis. We spoke about obesity. And the fifth thing is, remember, if none of these are there, the obstruction can be anything, right from your nose up to the level of larynx. Any obstruction can cause this condition of sleep disorder breathing or obstructive sleep apnea. So what are the most common symptoms they will present with? We have to ask them for nocturnal symptoms and daytime symptoms. So when a child comes to you and you're suspecting sleep disorder breathing, most common symptom you ask for is snoring, right? You first have to ask for snoring. Again, habitual snoring more than 3 times in a week. Is it there? Not there, right? You ask for apnea and hypopnea events. How do you ask that? Some of you all mentioned, is the child having gasping breath? Is the child having some choking episodes during the night? Second, is the child having restless sleep? Is the child waking up multiple times in the night, kicking around, moving around, rolling in bed? Is very important as sign of obstructive sleep apnea. Abnormal sleep position. Another person of you asked about nocturnal enuresis. A point which I was waiting to raise over there is, it has been shown one of the commonest causes for primary nocturnal enuresis is actually obstructive sleep apnea, right? Many times we ignore it, right? 30% is a study which shows right now is the prevalence of sleep disorder breathing in children with nocturnal enuresis. They need not have to have snoring. They might only manifest with nocturnal enuresis. And actually, if you go back and ask sleep history in a child who has nocturnal enuresis, you will be surprised that many of them may have snoring. But have we asked that question till now? No. Right? So remember that this can be a single alone risk factor for sleep disorder breathing, right? So when you go back and you see a child with nocturnal enuresis, either primary or secondary, the first question you can ask is the child snoring? Is the child having also restless sleep? If that is there, then remember that it is OSA causing nocturnal enuresis. And many of the patients, we have treated the OSA and actually the nocturnal enuresis has resolved, right? So 30% of them will resolve by treating your OSA as well. And if the child has nightmares, night terrors, it could be also manifestation of OSA. Now, remember we spoke about different sleep disorders. What you need to understand, they can also coexist. It doesn't mean that they're independent of each other. You can have a parasomnia with OSA. You can have restless leg syndrome with OSA, right? You can have different things coexisting with each other. So we ask for the other symptoms as well. Going to daytime symptoms, you ask for hypersomnolence. Now, hypersomnolence means what? The child is excessively sleepy during the day. Now, this excessive sleepiness during the day can be narcolepsy, can be OSA, etc. In Indian population, narcolepsy is very, very, very low prevalence, right? So most likely, if a child is excessively sleepy during the day, it most likely is sleep disorder breathing during the night itself. But you know what? You don't see excessive daytime sleepiness in children. Instead, you see hyperactivity. So one of you was asking, what are the clinical tips that I need to ask to make out whether this child has a sleep disorder or not, right? The most important symptom, that red flag you should ask for, is hyperactivity. If you ask, is your child hyperactive during the day, or you observe during your time itself, if this kid is running around, the child is hyperactive, the first thing I'll ask is obviously digital exposure, right? You'll ask how much digital exposure is the child having, is that the reason for the hyperactivity? Second thing you need to ask now is the sleep. And if you find out that the sleep is not adequate or the sleep is fragmented, the hyperactivity can be caused by that. You won't believe, in our sleep clinic, many of these children who are diagnosed with ADHD have actually had obstructive sleep apnea. And we have treated the obstructive sleep apnea and the hyperactivity has significantly reduced. So even in the Western population, a lot of the ADHD can be correlated to hyperactivity. We ask for cognitive difficulty, learning disabilities, mouth breathing, very common. We ask for morning headaches. This is something that we forget to ask. Once you start asking, you'll realize that it's a very important sign of sleep disorder breathing, and failure to thrive can eventually occur. So more than this, unique symptoms in infants with OSA, they can present with some amount of cyanosis, poor feeding and difficulty to gain weight, a weak voice indicating some upper airway obstruction, and frequent awakening with gasping. Remember that OSA can occur at any age. Again, don't presume it's adenoids. Just because it's an infant, you'll say, oh, infant cannot have adenoids, so it cannot be obstructive sleep apnea. The obstruction can be to something else, right? So OSA diagnosis can happen right from neonatal age group up to whatever age, right? So important for you to diagnose it. So how do you diagnose OSA? Right now, we said the clinical diagnosis is sleep disordered breathing. And from sleep disorder breathing, now you saw all this, you took the symptoms, you took the history, you're already suspecting that it is OSA. The only way you can say it is OSA or not is to do a sleep study. So the gold standard for obstructive sleep apnea is overnight polysomnography, because studies have shown that history and examination cannot differentiate between snoring, primary snoring, and OSA. Child is snoring, agreed. Is this OSA or not? How much is the level of hypoxia? How much is the level of apneas, hypopneas? How significant is this snoring or not, right? The only way we can find out is by doing a sleep study, which is the gold standard. Now, all of us presume that is sleep study very difficult or not. Till now, how many of you all thought that sleep study is something which is only a unicorn? It's like a unicorn. We never knew it existed in pediatrics, right? Many of us, right? So we thought that, come on, sleep studies in pediatric age group, who does that? Right? We do it very, very routinely. It is not very difficult to do. So what exactly do we do in a sleep study? It looks like many leads, but these are something which is relatively easy for us to connect. The first thing we connect is what we call as an EEG and an EOG, right? What do you think this EEG and EOG pick up in the sleep study? Tells you the stage of sleep. So we want to differentiate whether these issues are happening in non-REM sleep or REM sleep. And when we do our sleep training, we are able to identify these different stages of sleep, and these leads pick that up. Then we have something which is a nasal cannula and an oral transducer. These pick up the airflow. It tells you how much of air is going in and out, in and out. Then we have a chest belt and an abdominal belt. This tells you how much of, whether when the air is going in and out, is the chest and the abdomen moving in and out as well. Then you have a limb lead, which is what we use for looking for all these movement disorders. We attach a camera to observe, just like how you do your video recording we spoke about with the phone, you can have a camera attached as well. So using these minimal leads, we also attach a saturation probe to tell you the change in oxygen. By using these leads, you're able to do what we call as a level 1 polysomnography. What do you think you see here? A lot of squiggly lines, right? Now, all these squiggly lines are what we actually see in a sleep study. So when I come back after the sleep study next day morning, I come and look at all these lines and analyze these lines to understand whether this is whether this is OSA or not. Now, here what you see, these lines are all your EEG. This is what is telling me what stage of sleep is actually happening. This tells you the saturation. You're seeing 98, 98 is the saturation. You're seeing airflow 1 and 2, one nose breathing, one is mouth breathing, the air going in and out, in and out, in and out. Abdominal belt, chest belt going up and down, up and down. And here the carbon dioxide remaining at a constant level. So this is what we call as a montage of what we see during a sleep study. Can you see it suddenly changed? Can you make out the changes? So what all changes can you see? Can someone tell me what all changes did you see suddenly happen? Forget the EEG, come to this one. What happened to the saturation? It is going down. So you can see the saturation, which was up previously 98, 98, is suddenly beginning to drop. You can see previously the nasal flow was a proper one. It was going up, down, up, down. Here it suddenly stopped. Heavy breathing, stopped, heavy breathing, right? And you can see the thorax and abdomen were moving very nicely here. Here they are moving parallel to each other, right? So we see a desaturation, you see an obstruction, you see we connect the mic to see snoring. You see that the abdomen and chest are going completely erratic to each other. This is what on a sleep study we see and call as an obstructive apnea, right? So this is called an obstructive apnea. And if it is not a complete flat line, but the airflow is reduced. We call it a obstructive hypopnea. So we sit down in the morning and we look at all these waves every day in the morning and we label it obstructive apnea, obstructive hypopnea, apnea, hypopnea, right? And by that, we get a total number, right? We say how many apneas are there, how many hypopneas are there, right? And using that, we come across what we call as an apnea hypopnea index. So as a pediatrician, why you need to know this is you send them for a sleep study and they come back with a report, right? What do you do with that report? You have to look at this, what is called an apnea hypopnea index, right? So apnea hypopnea index, how do they calculate it? They take the total number of apneas, total number of hypopneas in the night. Let us say he had an apnea of, he had 80 apneas during the night and 5 hypopneas during the night. So this total number of apneas and hypopneas was 85. And he slept for 8 hours. So 85 divided by 8, your apnea hypopnea index comes to 10. And in the pediatric age group, if it is less than 1, it's normal. 1 to 5, it's mild OSA. 5 to 10 is moderate OSA. And more than 10 is severe OSA. So when they come back to you with this report, you will be able to tell whether it's mild, moderate, and severe. Why is this important? Is all your treatment will depend on whether it is mild, moderate, or severe. Tomorrow, if they ask you, doctor, my ENT surgeon said go for an adenoidectomy. You're the pediatrician. Can you tell me, should I do this adenoid surgery or not? Right? I always say do a sleep study. If you have no answer, one ENT surgeon would have said do it, one more would have said don't do it. And that is why they'll come to you saying, you're my pediatrician, you give me the answer. The best answer is to do a sleep study. And in the sleep study, I can tell you very objectively, right? Medico-legally and objectively, I will get a number. And based on that number, I can tell you do surgery or don't do surgery. So if you're very confused, do the sleep study and then we will take a decision. Can I have 2 more minutes? 3 more minutes? Yeah, sure. Okay. I'll go a little faster, right? Is this clear for you to take a decision? Makes sense? Yeah. So when you get this report, it will help you much better on what advice you need to give the patient. Now, when do we start treating? So we start treating when the AHI is more than 5. Anytime you get an AHI more than 5, you have to treat this child, irrespective of whether you have morbidities, no morbidities, etc. AHI is between 1 to 5, associated with some morbidities you have to treat, right? Or in the absence of PSG, suppose PSG is not there, then clinically it has to be really severe and only then we can treat. Your morbidities can be anything from enuresis, CVS, CNS, any form of associated morbidities. There are certain conditions where I told you have to treat irrespective of your sleep study or no. Those are your craniofacial malformations, neuromuscular disorders, genetic syndromes. You have to treat irrespective of your sleep study findings, right? Because they will have a significant AHI. Now, if I asked you an MCQ question, what is the gold standard treatment for OSA? What is the first option for treatment for OSA? MCQ question in PG, it's commonly asked. Oh, okay. Options, CPAP therapy, Montelukast, intranasal corticosteroids, adenotonsillectomy. How many of you all say CPAP therapy? Okay. How many of you all say pharmacological therapy? No one. Okay. How many of you all say adenotonsillectomy? Okay, fine. So that is the gold standard answer. Okay. So gold standard answer still remains adenotonsillectomy. Remember, I told you that adenoids and tonsils are not the only cause, but it is still the most common cause, right? So we will evaluate for the adenoids and tonsils. And if we find the adenoids and tonsils causing significant obstruction, then we will have to go for adenotonsillectomy, right? Now, if I ask you, when do I do adenotonsillectomy? When do I do that? That is when a sleep study might help you. The other option we have is obviously CPAP therapy, other surgical corrections, and pharmacological therapy. So the gold standard still remains adenotonsillectomy and it's the #1 treatment of choice. If your AHI, I'll give you a simple tip. You have done the sleep study, AHI is more than 5, your first choice should be adenotonsillectomy, right? I'm going to ask you a very, very controversial question. How many of you all do X-ray of adenoids? How many of you all? Okay. And if the X-ray of adenoids is normal, does it mean he doesn't have OSA? Child is snoring, you have done an X-ray of adenoids, it's normal, he doesn't have OSA. You said no, then how are you going to treat that child? You suspected the child has snoring, you have done an X-ray adenoids, it's come normal. So what do you do in that child? You have to do a sleep study, right? But other way around, if the adenoids are enlarged and the child doesn't have significant snoring, will you still operate the adenoids? Yes, no? You don't know. Okay. And suppose he has OSA, snoring is there. You already did a sleep study with Dr. Rajagopal. AHI is very high. It is around 8. Are you very sure that it is adenoids only? We don't know, right? So why I'm asking this is the standard of care has changed now. I have never done an adenoid X-ray because it is we've completely moved out of it. It's considered outdated right now, right? So endoscopies are the way to go, right? We're talking about simple nasal endoscopy where you just need to use it as an OPD endoscopy. You can speak to any of your ENT surgeons. I do it as a pediatrician myself. I have a simple nasal endoscopy because as pulmonologists we do it. You just put a nasal endoscopy and you have to observe the adenoids with a camera, right? And we have a particular grading. On this X-ray grading is so confusing. Some people say it's grade 2, someone says it's grade 3, grade 4. All that is too confusing. I want to physically see how much obstruction these adenoids and tonsils are causing and other causes. We end up seeing, recently we diagnosed few 3 cases with lingual tonsils being significantly enlarged. It wasn't even the palatine tonsil. It was actually the lingual tonsils which were grossly enlarged and causing OSA. All these can be picked up only with nasal endoscopy. So we also have to start changing the next practice of OSA where we don't do X-ray adenoids because it doesn't give you an answer to say, yes, I should do surgery or not. What gives you a clearer answer is to do a nasal endoscopy. So you can speak to your ENT colleagues who do endoscopies and ask for it. Say, please do a nasal endoscopy. I've done a sleep study, correlate both, and then go for surgery. So this is a landmark study which was done, which is called the CHAT study, which is shown that yes, adenotonsillectomy definitely helps. We do something called as DICE, which is drug-induced sleep endoscopy, where these are conditions where we don't do the endoscopy just by making a child sit and you do the nasal endoscopy. Complex cases. Now let us say I have a child with Down syndrome, right? And Down syndrome, I have already said that this child has, I've done a sleep study, AHI is 8 or 9. Now, in a child with Down syndrome, should I do surgery or should I do CPAP therapy? How many of you will say, if Down syndrome coming with OSA, I'll do adenotonsillectomy? I already told you that's the gold standard, first option, right? But it's a child with Down syndrome. Or should I do CPAP therapy? Why not adenotonsillectomy? I also told you another concept, right? Adenoid tonsils is not only causing an anatomical obstruction, it is causing an inflammatory obstruction. So removing it will also help, right? So that is where the role of this procedure comes, called drug-induced sleep endoscopy. So what we do is we induce sleep, physiological sleep as much as possible, right? And then we do an endoscopy using this physiological sleep. And then we see, we have a grading system which tells you how much of that obstruction is contributed by the adenoids and tonsils, how much of it is caused by the soft tissue collapse, how much of it is caused by the fat deposition, how much of it is caused by hypotonia during sleep, because it will not happen during when the child is awake. So you can't do that endoscopy that time. And based on that, we can take a decision whether you need to do adenotonsillectomy or whether you need to do CPAP therapy. So in these complex childs, not only are you going to do a regular endoscopy, if it's a complex syndromic child, don't refer for a regular endoscopy. Ask for a sleep endoscopy from your ENT colleagues. Now, what happens with some of them is that after you do just 2 more minutes, huh? Okay. What happens is even after you do adenotonsillectomy, they can come back. What is the percentage of those who come back? I told you, ENT colleagues will be shocked. 30%. So studies have shown 20 to 30% do have relapse or recurrence. Who are they? They're the ones who came with severe OSA. What is severe OSA? Definition? AHI more than 10. So what will happen? They'll come back to you with the report and the AHI showed 25, right? I will tell this parent, listen, removing an adenoids and tonsils is mandatory, right? Because it is enlarged. I did an endoscopy. It's the first line of management. But remember that there is a chance that it can recur. You have to counsel that. Otherwise, in our sleep clinic, because we run exclusive sleep clinic, they come back with this recurrence and they tell us, sir, this ENT doctor has not done a good job. They've not removed the adenoids properly. Now tell us what to do. It's not true. They've done the surgery properly. But the chance of recurrence is high because the risk factor of severe OSA is there. These people have AHI more than 25, they might have had even a soft tissue collapse. Obesity, risk factor. Inferior turbinate hypertrophy, Mallampati score 3 or 4, or any genetic conditions, a high risk factor for recurrence. In certain children, we go ahead and do CPAP therapy. Who are those who we do CPAP therapy in? Those, you've done your adenotonsillectomy, those 30% children who come back with recurrence after the surgery, we go for CPAP therapy. Those who have OSA with obesity, it's a very big pain to do surgery. Those with syndromic children, those with neuromuscular disorders, those who have CO2 going up higher on your sleep study. In these, my first choice will always be CPAP therapy. Now remember, CPAP therapy is not so difficult to do. It definitely has shown very, very good outcomes. These are all the studies which show the outcome of CPAP therapy, and definitely it has good outcome. Is there any role for medical therapy? The last concept I talk about is pharmacological therapy. Some of the parents say, doctor, I don't want surgery, I don't want CPAP therapy. Can you just give some medication? Is there any role? Yes, no? Yes. Which medication? Intranasal corticosteroids? Montelukast? Do you think it will help? Mild. What is the definition of mild? I just told you, what is the definition of mild? 1 to 5, because that's the perfect answer. In mild OSA, it can work. If it crosses beyond mild OSA, it will not work. Studies are clear on that also. So very easy for you. If AHI shows 1 to 5, yes, I can still try pharmacological therapy. You might have sometimes suspected severe OSA also because the snoring is so bad. But the AHI actually has come between 1 to 5. In them, I will first attempt pharmacological therapy. I use the same drugs you mentioned, intranasal corticosteroids and Montelukast. How does Montelukast work here? Montelukast mechanism is leukotriene receptor antagonist, right? So what has been shown in studies, when I told you what OSA is an inflammatory disorder, they've shown that leukotriene receptors are the main cause for the mild OSA. So using Montelukast does have a role. Though as asthma specialist, I keep saying stop using Montelukast, stop using Montelukast. But this is the only place where I say please use Montelukast if they have sleep disordered breathing. It can to some extent help. So we usually give a course of 6 weeks of intranasal corticosteroids and Montelukast. After 6 weeks, we call them back and we see the response. If the symptoms are much better, we give it for up to 12 weeks and then we stop the therapy. If within 6 weeks there is no change after using intranasal corticosteroids or Montelukast, we go ahead with either surgery or CPAP therapy. Right? The problem with medical therapy, as you know, the behavior is, I mean, you do have behavioral side effects of Montelukast, which is a big problem that we see. And after 12 weeks, if there's no response, it will not work. So don't keep on using that. We further have started our things with our dental colleagues of using oral appliances. Again, this also works only in mild OSA. Now, in mild OSA, we always send them for a dental valuation, right? Now, the dental valuation will look for overcrowding, overbite, high arched palate. Now, what I mean by high arched palate is, now let's say the palate is high and your adenoids may not be that enlarged, but that space where the adenoids is going to be very less, right? So one of the ways to increase that space is to bring down the palate. Instead of removing the adenoids, can we bring down the palate in those with mild OSA? So here is a condition where you saw a child has snoring, your nasal endoscopy showing adenoids are enlarged. You did a sleep study, but the sleep study has come as 3. Now you're going to be confused. Sleep study showing mild OSA, tonsils are enlarged, right? So that time, these devices are shown to work. They're called as rapid maxillary expansion, where they bring down the palate, right? And they have specific pediatric devices which have shown to be very effective in bringing down the facial shape and altering. Last but not the least, don't forget to treat obesity, right? Obesity in itself will bring down OSA. Now there are few studies in adult patients where they're using drugs, obesity drugs, like even metformin and trazodone, which are known to reduce obesity and indirectly reduce OSA. Whether it will be used in this morbid obesity in pediatric, we don't know, but treat obesity with your exercise and nutrition. So don't sleep on OSA. OSA is a form of sleep disorder breathing. Remember, clinical diagnosis is sleep disorder breathing, and then you make a diagnosis of OSA. Prevalence is very, very high. Don't ignore it anymore. Adenotonsillar hypertrophy may be the commonest cause, but it is not the only cause. Look for all children with genetic syndromes. Do not ignore any child with a genetic syndrome. First line of management is adenotonsillectomy, but remember there's a 30% recurrence rate with OSA. And any questions, I'll be very glad to answer. But I hope this gave you a broad overview of OSA. I could talk the whole day on OSA, but I just wanted to give you a broad overview and a lot of take-home points. I hope it was simple enough. Thank you.
Okay, so let's start straight away. So we have shared a link in the WhatsApp group so that you can answer the questions in between, and then we'll start the discussion that way. So it will be an interactive session. So the case histories will be short, but the discussions can be going as per what the doubts and the poll questions are. Okay, so starting with the first presentation, like it's a 6-year-old male child. History of snoring for last 3 to 4 months, about 4 days a week. Snoring becomes louder during episodes of upper respiratory tract infection, wakes in between nights and starts crying and then goes back to sleep. Breathing passes have been noticed in a 2 to 3 nights per week. And the daytime, kid is active and reports no daytime symptoms like excessive sleepiness. And grade 1 he is right now, and no drop in scholastic performance. So associated history and examination, no history of any nasal allergy, no history suggestive of asthma. Tonsils are grade 1, and nasal endoscopy showed adenoids of grade 3 with no other findings, and no dental malocclusion. So what will be the next best thing to do? So first the question is like, it's a typical case, as we have already seen, it's a typical case of a sleep disordered breathing in a 6-year-old kid. And what will be the next best thing to do? So you have a poll question to answer there on your link. You can start answering it.
Sir, I have moved the question answer to live screen.
So we'll give you another 10 to 15 seconds for you to answer. Then we'll start the discussion. So the options are adenotonsillectomy, you want to do a level 1 polysomnography, wait and watch with the nasal steroids, or to ignore snoring as there are no daytime symptoms. Okay. Hope most of them have answered it. Okay, sir, we can start discussing it. So we have right now known the delegates' answers.
Sorry, how old is this child? 6 years, right?
It's a 6-year-old male child.
6-year-old
Yes.
child. And the total duration of symptoms we need to know. How
For 4 to 5 months, sir. 4 to 5 months of loud snoring, at least 3 to 4 nights a week.
and you feel that it increases during the upper respiratory
Upper respiratory tract infections. Yes, sir.
So, see, again, like I said, clinically or practically, are we going to directly do a PSG versus are we going to give a trial, right? Now, here I'm going to talk about it more practically when we come to a case-based management here. What would I do if this child came to me, right? We go into further history of allergic. What is the cause for this, right?
True.
Most important cause, is there allergic rhinitis or not, right? I would have asked you questions of, does the child have recurrent colds over the past 6 months? Does the child have sneezing? Does the child have itching? Are there other features of AR there or not? On my clinical examination, he spoke about adenoids and tonsils, but what about the inferior turbinates? Were the inferior turbinates enlarged? Were there paleness or not? Is there allergic rhinitis contributing significantly to this child or not? Is something that we need to differentiate before I jump to a conclusion, right? I would still presume there is some component of AR here because the child is having symptoms only from 4 to 6 months, and there is obviously no daytime symptoms still manifesting. I would probably use a pharmacological therapy for a short duration of time, more practical for you to do. Give it for around 4 weeks. Assess after 4 weeks of giving intranasal corticosteroids whether there is a response or no response. Within 4 weeks, you will be able to make a very clear picture. If there is a response, then I would go more in favor of an allergic rhinitis and evaluate further. If there is no response, then I would probably think of whether we need to consider a polysomnography. So I think in this child, although all of you have mentioned PSG, yes, eventually PSG is something that we might consider in sleep disorder breathing, but the duration of symptoms are relatively shorter. There are no associated daytime symptoms. It's the typical age when we're going to
Yes.
see it. The age is again an important factor, right? We use something called as a 3-hit theory, where if the child is less than 2 years or more than 6 years, then it is very clear that this OSA, there's something very, very unusual. It can be beyond the adenoids, because less than 2 years or more than 6 to 7 years, there might be something more. That time we think of going directly for evaluation, right? But here I would still do an intranasal corticosteroids, wait. But I think you've not mentioned you've already done your nasal endoscopy. We need to talk about whether there are other factors contributing.
Yes.
I would do nasal corticosteroids first.
I agree with you, sir, because in the history, the kid was snoring 4 times in a week. So it makes him a habitual snorer, right? And the snoring was loud during the upper respiratory infections. But in the history, there was no nasal allergy history. That does not correlate for me. We need to have more information about the nasal endoscopy, where it told only the grade 3 adenoid, regarding the status of nasal mucosa, the status of turbinates and septum. That all has to be seen. Anyhow, eventually we will need a polysomnography, but for a short course, we can go for pharmacotherapy, and then we will go for PSG and decide more.
Yes. So Sir, can you tell me like who are the patients where we can skip polysomnography and directly proceed with adenotonsillectomy in typical SDB symptoms patients? Yes.
Um, so now that we have ENT colleagues also amongst the crowd, there will obviously be conflicting views as to who do we operate on, who do we not operate on. If you look at the American Academy of Pediatric guidelines, they say any child, irrespective of the age, if they're present with sleep disordered breathing, you do a polysomnography. But when you look at the American Academy of Otolaryngology and Head and Neck Surgery, look at their guidelines, they will say if a child is less than 2 years having snoring, if the child is having adenotonsillectomy that is planned and you're suspecting sleep disorder breathing, child with obesity, or you do a clinical evaluation, you are saying that it's not correlating these symptoms with whether I should operate or not, then they would probably say do a polysomnography. I would still say that in this case, obviously we know that it is going to be adenoidectomy or adenotonsillectomy. Polysomnography will probably help you understand what is the baseline sleep of this child in case the child comes back with a recurrence.
Okay.
You always have a study. And if you see the phenotyping that you do, there are phenotypes 1, 2, and 3. This child typically falls under the phenotype 1. Although if there is a resource limit setting, you don't have a polysomnography available, you can go ahead with an adenotonsillectomy. Gold standard would still be a polysomnography to start off with.
Okay. So regarding the phenotypes, like what about a short brief on 1, 2, 3 phenotypes for the audience sake?
Short ones are the first one is just a child with sleep disordered breathing, not having any comorbidities. Phenotype 2 is where you have obesity that is causing the sleep disordered breathing or OSA. And type 3 is the newer when we have dysmorphism or syndromic children presenting with obstructive sleep apnea.
Sure. Okay. And so Dr. Bharath sir, like what is the usual duration of nasal steroids for you to expect response? And do we really expect the size of adenoids to come down? This is the most common misconception which we usually have.
So the size of the adenoids per se doesn't reduce. It is mainly the inflammation that is going to come down,
Okay.
right? So we use up to 6 weeks to 12 weeks of intranasal corticosteroids, but we need to reassess within 4 weeks. If within 4 weeks the response is significant, you will be able to tell that it is responding or not responding.
Okay.
So I would give 4 weeks. I would say come back after 4 weeks. I would use 4 weeks of intranasal corticosteroids and montelukast and ask them to come back at 4 weeks and reassess the child. You will realize that many of them who fall into that OSA mild category, they will show response. In them, I finish the 12 weeks therapy. And after 12 weeks, we stop the medication and then take a decision on what to do next.
Okay. Sabri sir, like what is the usual indication you encounter for an adenotonsillectomy, and any surgically you need to do different techniques based on the indications?
Yeah. So regarding the indications, now we started to see very less and less of cases of infective indications for tonsillectomies and adenoidectomies, and the most common indication would be, so from now on I have to say the sleep disordered breathing. Mostly patients would be brought with complaints of snoring and disturbed sleeping. They are probable OSAs, so we don't know. So most common indications now is sleep disordered breathing, which we see. And regarding the surgical techniques, like madam already told, we hardly use the scooping technique, curating technique for adenoid anymore. We do under vision using endoscopy. That is the main change. So we can visualize and we have clear cut boundaries where all we have to go and clear the disease and where not to touch and where not to stop to reduce the complications. So the complete removal of adenoid is possible. So there is a debate between ENT surgeons also whether to go with microdebrider or coagulation, and some people use hybrid technologies also. But with both these techniques, complete removal of adenoid is possible. Coming to tonsillectomies, we do coagulation tonsillectomies, and in adult OSA, when we speak about OSA in adult age group, the upper area of the tonsils which goes and pushes the soft palate, they are usually considered as the offenders and reason for the tonsils. So what they say for tonsillectomies is you go extra capsular, go the tonsil, you start with conventional sort of plane, and then when we come down to the lower plane, they come intracapsular to reduce the post tonsillectomy bleed. But mostly with in children, we used to do complete tonsillectomy only, but with coagulation.
Okay. So moving on further with the same case, So the polysomnography has been done for the patient, which we have mentioned, just like a 6-year-old with typical sleep disorder breathing symptoms. A polysomnography shows an AHI of 3 events per hour, which comes under the purview of mild OSA. Now, further, like, what should we do? Now we can answer the question there, and then we'll start the discussion again. Okay, sir. So we can start the discussion again. So now we have again to the first step now.
So I think the answer is quite good because I think this is where we spoke about mild OSA.
Yes, sir.
If the HI is between 1 to 5, I would still go ahead with pharmacological therapy with 6 to 12 weeks. So I think that answer is perfect. Yeah. So we do 6 to 12 weeks of pharmacological therapy and then we take a call.
Yes.
But let me add additional points here. Now, what do you do if the pharmacological therapy doesn't work? Right? Are you going to ask that, or
Sir,
if the pharmacological therapy doesn't work here?
yes, sir.
So then what do we do next?
Yes, sir.
right?
That will be the next part.
Sure. Okay.
Yeah.
Do you want to ask the question?
Yeah, you can continue that.
Oh, okay.
That's not a question actually.
Okay, it's not a question. Okay. So I think this is again very common. Now, again, I said give 6 to 12 weeks. So you give intranasal corticosteroids, you give montelukast for 12 weeks, right? The child was doing slightly better. You stop the therapy and then go home. After 1 month, they come back. And they say, again, the child is snoring. Or again, the child is having these apneic episodes. So how do we handle those children, right? Again, you're fall into category where AHI is less than 5. Plus, you're having these particular issues of snoring again coming back. Here, of course, endoscopy plays a very crucial role, right? Many times they repeat a nasal endoscopy and look at the adenoidal grade as well as the tonsillar grade. The adenoid or the tonsillar grades are significantly high, then your first choice would again to go for surgical management before we go for anything else, right? But in the case, suppose the adenoidal grade is not that significant or the tonsillar grade is not that significant, then we have 2 additional therapies. So this is where in our recent, we had an OSA conference recently in Bangalore, where we had an integrated group which spoke about, we have ENT, lot of ENT colleagues, lot of dental colleagues, and a lot of us were there, pediatrics and pediatric pulmonologists. So the question here came as to why the dental colleagues, there were almost 30% of the group were ENT, 30% were dental, right? Why did all these dental colleagues come to our OSA conference was to understand the dental management of OSA. So there are newer therapies which have come up now, which is called as myofunctional therapy. So what happens with myofunctional therapy? I showed you the dental appliances. So either they use dental appliances to help us bring down the palate and therefore increase the space. So nasal space becomes more. So of course, the space becomes more, the child will find it easier to breathe. They use something called myofunctional therapy, where with the form of exercises, you're able to bring down the soft palate and bring down the palatal arch itself and strengthen the muscles. We also spoke about the muscles collapsing to some extent, right? That strengthening of the muscles also happens. And this is what we call as myofunctional therapy. So there are a lot of specialists. Surprisingly, in Tamil Nadu, there are a lot of myofunctional specialists. So even in our conference, many of the myofunctional dentists who came were all from Tamil Nadu, actually, from Coimbatore and all these places. So they do myofunctional therapy, and that has shown significant response as a non-surgical option in children with mild OSA. So I would still say mild OSA, we do repeat a nasal endoscopy. If still adenoids and tonsils are enlarged, causing significant night and daytime symptoms, I will go ahead with surgery, irrespective of the sleep study. But if they are not significant, we will think about dental maneuvers, either in the form of appliances or myofunctional therapy if pharmacological therapy fails.
Okay. And
Yeah, again, regarding this case, it was grade 3 adenoids, and the AHI showed it is mild. Actually, it is my request to pediatric population and pediatric pulmonologist population, as already sir has emphasized, X-rays are often misleading. Please get a nasal endoscopy from your ENT colleague, because we need to see whether it is adenoiditis. And in the time of inflammation, if you take an X-ray, it'll the grade 2 may show as grade 3. And the pharmacological therapy, if you give and the patient gets better, maybe that inflammation has come down, and that's why the patient was getting better. Maybe the actual adenoid is grade 2 only, it's not 3. That's a possibility.
Yes. So, Sabri sir, and in a sleep study prior to adenotonsillectomy, if done, what may alarm you, or what you usually see in a sleep study if it is done prior to planning a adenotonsillectomy
Yeah, of
in a
course,
in a patient with grade 3 adenoids?
yeah, of course, I'll take help from my pediatric pulmonologist to read the complete polysomnograph. What I will particularly look on to as the AHI, as usually pediatric AHI scoring is different from that of adults. In an adult polysomnogram, if he is having 8, he then we don't bother much. But in pediatric population, 8 is significant. So that is an indication for surgery. So that one thing, and how much low the oxygen saturation goes down. What is the LSAT? That is also a thing which I will look for.
Sure.
Whether it is going very low, below 80.
Okay, sir. So, Dr. Nagarjun, like,
So I think the point we need to also make is that see, pediatric PhDs, like we said, is not similar to adult PhDs. In adult, you can just look at only the AHI and make a decision. If it is very obvious, like about 10, you don't even need to think twice. You have to just advise whatever you need to advise. In all these borderline cases, see, many of the cases I get 5.6, I'll get 6, 7. There you're like, listen, I don't know whether it's here or it is there, right? And surgery is not a mild thing for us to just advise the parents in such situations. That is where we, when we do our training, like many of them who undergo the pediatric sleep training for 6 months, 7 months with us, we teach them how to read these sleep studies in detail. That one epoch, what I showed you, is actually 2 minutes. It's a 2-minute image of the sleep. The fellows and the sleep people trainees, they go through every epoch. You can't just say calculate the total apneas and hypopneas and give it. So you have to analyze it, and there is a certain way by which, even if the AHI is mild or moderate, we're able to come to a conclusion by looking at every epoch where the saturations happen, how many times the child has woken up. We didn't even speak about the arousals. The AHI may be low, but the arousal index might be very high. So the child might be still waking up multiple times. Now remember, when I say waking up, you're talking about macro arousal. Macro arousal means the child is fully waking up. On the sleep study, we also look at something called as micro arousal. That means only on the EEG the child has woken up, but the child is completely not woken up. You don't know about these micro arousals till you do a PSG. These micro arousals keep tell you that, listen, the child would have woken up 80 times the EEG has actually woken up, but the child is physically not woken up, right?
True.
That is a very important sign. Imagine you waking up 80 times actually in the brain, but not physically waking up. These are all subtle markers which add. So even if the AHI comes somewhere in the borderline, I would go back. So my fellows go back to the PSG and we read the PSG again. We look at actually how many times the child has had micro arousals, right? How many times, like I told you, sympathetic activity we just spoke about. We said how many times has the sympathetic activity happened? How many times has the oxygen desaturation happened? And what is the lowest saturation? So we also have subtle markers you have to go back to in these borderline cases and then make a decision. Suppose even the AHI is 6, but the arousals are very high, the oxygen desaturations are quite significant, the lowest level is high, I would still go ahead with surgery in such a child.
yes. And Dr. Nagarjun, in case the AHI is very high, say 30 or 40, how do we proceed ideally in such cases, which we usually don't expect in a straightforward pediatric OSAs? How do we proceed, and how often do you see a non-syndromic child having such high AHIs?
If you listen closely to Dr. Bharath's talk, when you have a very high AHI on your sleep study, that means there is a chance of residual OSA, even though you might want to plan the child to have an adenotonsillectomy. When you have a very high AHI, say 20 or 30 in such a case, you can expect some post-operative complications. In such cases, what we do is we consider starting them off on perioperative CPAP. We start probably 2 to 6 weeks prior to the surgery. We allow the child to get used to the CPAP, because when you suddenly get rid of the obstruction that is there, that is in this case the adenoids or the tonsils, what can occur is there can be a re-expansion pulmonary edema or a negative pressure pulmonary edema when you suddenly remove the cause of the obstruction. In such a case, having a CPAP or a BiPAP therapy perioperatively and post-operatively, this is something that you need to discuss with the anesthetist as well. They will determine how deep they want to take the sedation and what post-operative care they can give. Any child that is having an AHI of more than 20, you need to be careful. Consider doing perioperative CPAP. Consider doing a DICE directed surgery, that is whether it is only the adenoids and the tonsils that is contributing to this obstruction, or is there anything else.
Sure. Thank you. So let's proceed with the second case. So this is a Down's child, a 5-year-old male child, Down syndrome, came for routine evaluation and was having an URI. When sleep history was taken, parents deny any sleep symptoms, and ENT evaluation showed allergic changes with grade 3 adenoids, and tonsil enlargement was grade 2. What should we do now? Yes, sir. So this is the most common thing, like parents denying symptoms of sleep disordered breathing. Like absolutely, they are either unaware, or they have not seen the child do it, or they don't know that the symptoms are actually causing the child to be disturbed at sleep, or they actually don't have symptoms. So how do we differentiate this? In a Down child, we already know that they are going to have OSA by the age of 4 years. That's fine. But if it's a non-syndromic child, this problem will need to be addressed.
Sure. So it's again, you have to differentiate between a syndromic child and a non-syndromic child.
Yes, sir.
In a syndromic child, the chance of having OSA in the absence of snoring is very rare. In a non-syndromic child,
Okay.
in a regular child. So we say that the chance of you saying OSA without having basic snoring is very, very less. Whereas in a syndromic child, the chance of having OSA even without clinical symptoms is very high.
Right.
That is reason is that the symptoms don't manifest because here it is not only the adenoids and tonsils contributing. You're going to have multifactorial contributions. Just the muscles being hypotonic contributes to the OSA. You have hypoventilation because of that. So here the parents may not, how is the parent going to observe hypoventilation? Remember when I put up the spectrum, I showed you one condition called hypoventilation, right? Obstructive hypoventilation syndrome. That is something which you cannot pick up history at all. Those are
Yes,
things
sir.
which you can pick up only on a sleep study. So they actually don't have symptoms. It's not like the parents are not seeing it. They don't have obvious symptoms in a syndromic child. So which is why most syndromic children, the guidelines, right from Prader-Willi syndrome society, now they have all these individual societies. So all these individual societies have very clearly made guidelines now as to what age should you do a sleep study in these particular syndrome. In Downs, it is said it has to be 4 years. Prader-Willi syndrome, I do a lot of Prader-Willi work because we have a Prader-Willi center for sleep actually. So in Prader-Willi syndrome, a lot of our endocrinologists give growth hormone, right?
Yes.
Growth hormone is the most common drug used in Prader-Willi syndrome to reduce the hypotonia and the OSA and obesity. Everything comes down with growth hormone. But the current guideline says you cannot give growth hormone till the sleep study is normal. So since the endocrinologists are very tuned, they write, the pediatric endocrinologist writes saying, I want to start growth hormone, kindly do a sleep study. We do a sleep study, make sure it is normal, do a CPAP therapy, then they start growth hormone. And the growth hormone brings down the obesity in this Prader-Willi, and indirectly the OSA starts coming down and we go off CPAP therapy. But when you take the history initially, none of these children will have any sleep symptoms.
Okay.
But even at early, now what is happening, the endocrinologists want to do growth hormone the moment they diagnose Prader-Willi. So they refer at 6 months. I have patients who are coming at 6 months saying that the endocrinologist has said start growth hormone therapy, do a sleep study and give us. So we have to actually give a physical letter now saying kindly issue growth hormone. The child is eligible for growth hormone therapy or not. So in our sleep clinic, we have to actually issue that because now even the Karnataka government is giving growth hormone free. So the government doesn't give free till we give the clearance saying the child does not have sleep apnea. So in these conditions, we obviously don't have any symptoms, but you have to routinely end up doing a sleep study in many of them.
Sure. Anything to add on, Dr. Nagarjun and Dr. Sabari, sir?
So, although the guidelines for Down syndrome mentions do a sleep study by 4 years of age, you don't have to wait till 4 years of age for them to do a sleep study. If you have a 2-year-old with Down syndrome and who has symptoms of sleep disordered breathing, you still do a polysomnography. So, gold standard is do a polysomnography the moment the parent recognizes the sleep disordered breathing in a child with genetic syndrome. In Downs, you have guidances, but in other syndromes, you don't have. So, clinical evaluation becomes very important.
Sure. Thank you. So coming to the third case, the obese OSA, a 10-year-old female kid, history of snoring for last 3 to 4 years, about 3 days per week, no night awakenings, no breathing pauses have been noticed. Daytime, the kid is active and reports no sleepiness. Grade 5 and no drop in scholastic performance. Associated history, symptoms of nasal allergy on almost all the days since last 2 years. No symptoms suggestive of asthma. Grade 3 tonsillar hypertrophy. Nasal endoscopy shows grade 3 adenoids with no other findings and no dental malocclusion. BMI is more than 95th percentile for her age. So polysomnography showed an AHI of 30 per hour. So is adenotonsillectomy indicated directly, or can we treat with nasal steroids and wait in this patient? Please use the second link which has been shared. Yes, we can start the discussion. Like most of them have answered it.
Okay, so how I would manage this child is considering we have a comorbid condition. So we need to look at the comorbids which I mentioned. One is obesity, one is syndromic, etc. Now, a child who's coming with severe OSA with obesity and adenotonsillar hypertrophy, having all three components here. And remember, the adenotonsillar hypertrophy is at an age which I said is outlier. I said less than 2 years, more than 7 years, right? It's fallen in the above 7 years, right? So here is something unusual. And children to have AHI as high as 30, 35, etc. is very, very unusual. So I would first do a drug-induced sleep endoscopy in this child. So we do something called as a drug-induced sleep endoscopy and identify which level of obstruction is the most significant, right? Of course, adenoids and tonsils have to be removed, but shall I remove it right away, or should I also do something additional to remove the adenoids and tonsils? Now, suppose I see that there is no other obstruction anywhere other than the adenoids and tonsils, I would first go ahead and do an adenotonsillectomy, and then we repeat a sleep study after 6 weeks and then see whether the OSA is resolved. In a lot of these patients, like I said, the recurrence of OSA is not because of the way you remove the adenoids. It is because they have other complex conditions which is causing the recurrence or the relapse. So in children with obesity, there are various other factors which will cause the relapse. So some of these patients, when we 30% of them, we come back after 6 weeks and they will have again OSA. The HI may not be 30, but the HI might be 9, the HI might be 10. Then you're going to say, like, what? I did a surgery and now you're saying the HI is still 10, they're still having problem. Here we start CPAP therapy. So many of these children end up going for CPAP therapy. Now, like I think Nagarjun raised another important point of perioperative CPAP therapy. The reason we started talking about this is of some of the cases we started encountering of these residual OSA. So we had 2 or 3 cases where the ENT surgeon was very clear. He has done actually a sleep study. The AHI has come around 30, has come 40 in this child, 40 or 45. And the ENT surgeon has gone ahead and done an adenotonsillectomy. Obese child, severely obese child. The child has not been able to be extubated. So it was very difficult to extubate this child. And that's when they called us and said, listen, you have to start intervening now. We're not able to extubate. Carbon dioxide is building in this child. And it took really long to get this child off the ventilator. And then eventually the child was started on CPAP and BiPAP therapy, right? Could this have been prevented by using perioperative CPAP BiPAP therapy was what we had to evaluate. Now, there's an important condition which I didn't speak about, which is very new. I mean, I wouldn't say it's new, it's rarely diagnosed, but we are seeing it commonly, is a condition called Rohat syndrome. Okay, have any of you heard of Rohat syndrome? Okay, few of you. So Rohat syndrome is a condition which has rapid onset obesity, hypoventilation, hyperphagia, and autonomic disturbance. ROHHAD, right? So rapid onset obesity, hypoventilation. So these children are actually having severe obesity and hypoventilation. So in them, sleep apnea and carbon dioxide buildup is very, very high. So in some of these patients, we actually end up doing CPAP therapy before we go ahead for surgery. So we stabilize them. We start CPAP BiPAP therapy, stabilize them first, then it's safer for the surgeon to go in for surgery. Surgeons to have no complications, no post-operative complications. Then after the surgery, we repeat a sleep study. We see that the AHI is coming down and we slowly wean off the CPAP and BiPAP therapy. So in your obese patients, one question you need to ask is this obesity rapidly developing? If some of them say, no, the obesity, doctor, it's not like obesity which has been there for very long. Only since the past 1 year, this child has rapidly gained weight and developing all these OSA symptoms only since past 1 year. Rohat syndrome should be on our top diagnosis then.
Yes, sir. And Dr. Nagarjun, how do we assess a child post adenoid tonsillectomy? How long to wait for resolution of symptoms, and when to repeat sleep study, or any specific indications for repeating a sleep study in patients which we have discussed previously? Yes.
Like Dr. Bharath already mentioned, we have to do a repeat sleep study at least 6 weeks after the adenotonsillectomy. And if they, even if then they still have some residual OSA, then we go and do a DICE. Based on the DICE, we plan our management. In this case, that the obese child, some parents might obviously say, I don't want my child to undergo surgery. Can I only do CPAP or BiPAP therapy? We can probably counsel them saying that CPAP or BiPAP therapy will probably not completely clear off all your problems. Neither is only by doing a adenotonsillectomy, but we can also tell them that the pressures that they require on a CPAP or a BiPAP, when you do a surgery and not do a surgery following by BiPAP, is significant. So you are using lesser pressures to open up the airways when you have an adenotonsillectomy that was done prior. So I feel 6 weeks is what we wait to do a post-operative repeat polysomnography
Sure. And if there are symptoms.
if there are symptoms.
Sure.
Yes. Or if there are any comorbidities or they're syndromic, you have to repeat it either ways.
Sure. And any comment by Dr. Sabari, sir?
Yeah, adding on to what Nagarjun sir said, uh, see, there may be residual OSA rather than relapse of OSA in this child after adenotonsillectomy because of various other causes contributing to OSA. But when we speak about CPAP as an option, when the parents are asking or they are not ready for surgery, see the adenoid and tonsil, these are static obstructions. And if the obstruction which is caused by a palate or lateral pharyngeal wall, they are dynamic and that can be dealt by CPAP easily. And removing a static obstruction definitely helps and facilitates for the CPAP compliance also, if I'm right.
Again, it is a parent choice. So what I do is I still leave it on the parents, right? We can't completely make the decision if they don't want surgery. Some of them are very clear. I don't know. They have this mindset about general anesthesia. They are very clear there. Like, we don't want general anesthesia, right? And their parents are very clear. So will CPAP help? Yes, it will help. The question of the parent is, will this adenoids go away with age? Now, suppose we see it in that range of where 7 or 8 they're coming, and they say, no, my pediatrician said, the adenoids may shrink with age. Can you start CPAP therapy? So we give them a trial. So we put them on CPAP therapy. If they're completely resistant to surgery, a lot of my patients are doing well. And then we repeat the sleep study after a year and we tell them, see, now do you want to see whether you want to remove or not? Surprisingly, some have come down with CPAP therapy. And their parents are much more the parents are happier. The kid also doesn't want to remove the CPAP. It's their choice, right? If some of the kids are very comfortable with it, they continue with CPAP therapy. And with age, we keep repeating the sleep study to see at what point they want to come off. And this also is a misconception that CPAP is difficult in pediatrics. It's actually quite easy. A lot of the children are very comfortable with CPAP therapy. It's used only in the night. They think it's like some superhero. They become a superhero and connected a CPAP machine. They're very happy with it. So I leave the choice to them. I'll still tell them this is the first option. But if you are completely against it, some of them go into additional CPAP therapy.
Sure. Moving on to the last question. How do we counsel parents prior to adenotonsillectomy? You can use the second link to answer this.
Is in this patient or
Same patient, sir. Like
this
we're
patient?
proceeding with the same case.
The answers are different and the answers you gave previously are different. These are different than what you put
Next
up.
question.
Yeah.
Next question. The previous question, yes. The previous question. Okay, so this we have already discussed as a part of our discussion.
So can you put up that slide? We'll see the
Yes,
questions we didn't because it's not matching.
Slide is the
Yeah.
question, yes. So these are the options. So we can start discussions. The poll has been.
So I think this is something we discussed when they have an associated comorbid condition. They have two high risk factors here. One is the OSA is very severe. It is coming into your about 30, and the child has associated obesity. So I will tell the parents, yes, adenotonsillectomy is indicated in this child, but there is a high chance of residual OSA in 30% of these patients because of soft tissue collapse, fast tissue deposition. So actually I write a treatment plan. So I'll tell them this is all the treatment plan that you need to do. First, go ahead with adenotonsillectomy. After 6 weeks, we repeat the sleep study to rule out residual OSA. If residual OSA is there, we do CPAP therapy. In addition, you do weight reduction with dietary management as well as your physical activity. So this entire pattern should be followed for this.
Sure. Thank you, sir. So now the forum is open for audience questions. Yes, sir.
Can you please give the mic?
Question to Sabari sir. Sir, with the visualization of adenoids with nasal endoscopy, according to the grade, we can prescribe intranasal steroids, or if it is grade 4 and before doing the sleep studies, child is symptomatic occasionally with URI symptoms and having sleep disordered breathing. Shall we try, as sir told, we can leave it to the parents' decision. But in grade 4 adenoids, whether the intranasal steroids will work. And I recently learned that steroids should be used, we have to use the machine pointing towards the ears, not pointing towards the nasal septum. I recently
Yes,
I saw that
two parts. Your question has two parts.
Yes,
One
sir.
thing is whether the use of steroids has anything to do with reducing the size of the adenoids, and in usage,
Yes.
how we deliver the drug.
Yes, sir.
So regarding the size, actually the intranasal corticosteroids work to reduce the inflammation, reduce the secretions. As such, the shrinkage of adenoids doesn't happen, sir.
Okay.
And regarding the drug delivery mechanism, what when we try that, it has to be directed towards the ear.
Yes.
I mean, for the patient to know, actually the idea behind that is it is to direct towards the terminate. Why? Because if we direct towards the septum, sometimes what will happen, the jet of medicine which is touching the septum, that will induce in itself, that will induce sneezing and irritation by itself, and the compliance will not be good. So that is the one thing, sir. Otherwise, some deviations of septum will always be there. 60% of patients will have some or other degree of deviation. Perfect straight line septum is very rare. So in that case, if you direct slightly laterally towards the turbinate, it will go either directly behind the nasopharynx, it will touch the adenoid, or the turbinates. It will not hit the septum. That's the idea behind it, sir.
Okay. Sir. Questions. We had Rohat syndrome like 2 months back, sir. Like a 5-year-old with rapidly gaining weight. 5-year-old, 57 kgs, sir. So after 2.5 years only, she has gained a lot of weight, and she presented with chest retractions and hypoxia. Got better with CPAP. Like PCO2 was 120 on arrival, sir. Like got better with CPAP, and we removed the CPAP. Again, she was going back to the same stage. We didn't do PSG, sir, and the we searched the literature. It was looking like Rohad syndrome. In those cases, I mean, what like CPAP? How long we can do, or what other options are
So
there?
first you need to do genetic testing to rule out other causes
Yes.
for hypoventilation. So first get a regular exome sequencing done to
Yes,
rule out
cen-
hypoventilation
cen-
syndromes, because central hypoventilation syndrome, what we talk about, these Ondine's curse and all, can occur at any age. It need not, this child is obviously hypoventilating because CO2 is quite high. It can occur at any age. So you need to get a genetic screening to rule out other causes before you make a diagnosis of ROHAD actually. So ROHAD has to be, other causes should be excluded to make a diagnosis of ROHAD. So genetic screening first, get a sleep study with your ETCO2 monitoring, and start the child on BiPAP therapy. CPAP will not work in this child. BiPAP has to be given and the pressures has to be monitored. You have to keep repeating the sleep study yearly to readjust the pressures. So we use what we call as a titration study. So every year we do a titration study to readjust the pressures for this child. At what stage will the child come out of this once the obesity comes down or no? We don't know. We have to still monitor these children. Yeah. But the few rohats that I have, they've lost weight. We started BiPAP therapy. They've lost weight dramatically after starting BiPAP therapy.
Like home BiPAP, sir?
Oh, yeah, home BiPAP therapy. But the sleep study is still showing hyperventilation. We removed the BiPAP and said, oh, this child has recovered. Like
Yeah.
obesity has come down completely, right? And we did a sleep study without anything. And the sleep study still shows hyperventilation and OSA. So how long it's going to continue, we don't know, but we had to restart the BiPAP in these children. Most likely it's a genetic ROHAD. Surprisingly, we're picking up a lot across India now. Many case reports are coming with ROHAD syndrome right now. Yeah.
Yes, sir. And your comment about Montelukast with antihistamine, sir, the combination.
No
Because
role.
we pediatrician we always use Montelukast.
Yeah.
Other specialties they use combination.
Yeah. So if you talk about scientific evidence base, there is no role in the combination. It's not a fixed drug conjugation, which is rational. It's considered an irrational combination, primarily because Montelukast dose as well as the antihistamine dose, how long you use it for. Antihistamine, we use it for maximum 1 week to 2 weeks. You're not going to use it beyond 2 weeks. Whereas Montelukast, the course is for 6 weeks to 12 weeks. So both of that don't match because you're supposed to use one for 2 weeks, one for 12 weeks,
Yes.
right? So that is one of the primary reasons why the fixed drug combination is of no role. You want to use both, use Montelukast separately, use antihistamine separately. Antihistamine should be withdrawn and Montelukast should be continued.
Yes, sir.
For intranasal corticosteroids, so usually less than 6 years I use mometazone, above 6 years I use fluticasone. So less than 6 mometazone, above 6 fluticasone, and the dose less than 12 years, 1 spray both nostrils, above 12 years, 2 sprays both nostrils.
Some parents comes with the complaints of mouth breathing, sir, without any comorbidities and without any infections, no allergies. Throughout the year, mild mouth opening.
So it's called habitual mouth breathers.
Yes, anything we have to screen or anything?
Very good question. Why I ask is very commonly seen. Habitual mouth breathers are commonly seen. And one more point I wanted to raise is post-surgery. Like I've done adenotonsillectomy. We've repeated the sleep study. AHI is also normal, but his mouth is not closing because he's had OSA for so long that his mouth doesn't close, right? So these patients respond to myofunctional therapy. So that is where the studies have come in. They use this therapy, myofunctional therapy it is called, where they stimulate the muscles and they strengthen the muscles to close the mouth. And that is called myofunctional therapy. And they've used that mainly for these habitual mouth breathers. So it's mainly by muscle strengthening. They use different muscle strengthening exercises in a structured manner and the mouth tends to close. But if you see a mouth breather, first thing, rule out OSA. If it is not OSA, then we call it habitual mouth breathers. Then we use myofunctional therapy for them.
Even 2 to 3 years, we need to
So
do.
2 to 3 years little difficult to do because they need to understand the exercises. For mostly above 4 years, they do myofunctional therapy. Less than 2 to 3 years, little difficult. They use those dental appliances to help the palate to come down. But they're also little difficult because they don't keep it. But like I said, first rule out OSA. Don't presume that just because the child is 2 years, there is no OSA. So even if it's 2 years, it's a risk factor for high risk factor for complex OSA. So whatever age group, rule out OSA first. If the OSA is negative, AHI is normal, then we say it is habitual mouth breather. If it's habitual mouth breather, either appliance or myofunctional therapy. Among these, myofunctional therapy is the first choice. Like the other point I wanted to make, post-surgery, this is something which we newly have learned as well, that there are many patients even after surgery who don't close their mouth. They become habitual mouth breathers. So in them, till now we said, leave it, we've done surgery, wait, it'll close. But we should always remember, what is the problem if you breathe in the mouth? You're breathing anyway, right? The child is breathing. What is your problem? The child is not snoring, the child is breathing. Dryness of the mouth, yeah, then? What? So that comes to the function of the nose, right? We forget the nose has a very significant function of humidity, filtration. All these are overcome because you're not breathing through the nose. So which is why mouth breathing is not a healthy sign. So we need to do all these therapies to close the mouth. So I would say myofunctional therapy.
Adding on to what sir's told about myofunctional therapy, regarding the mouth breathing post adenotonsillectomy, once the child is mouth breathing, we have to evaluate, we have to, if there is a significant adenotonsillar hypertrophy, you have to go for adenotonsillectomy, and post-operatively, we used to advise before the evaluation and the knowledge regarding this myofunctional therapy, we used to advise the parents to give the children some kind of a gameplay, like we ask the child to keep a card between the lips and then ask the child to climb the stairs and come down. And if the child drops that card, she loses a point. And if it does not drop, she gains a point. That's the gameplay. So for her to keep the card between the lips, she has to flare up the nose and she has to breathe through nose. So that to develop the habit of using that nasal ala, which was not been used, which is a feature of adenoid phases, the nasal alar flaring, which is not there. And since the nasal corridor was completely shut for so long, so child did not learn how to use that. So we used to do that game. So we can add on other myofunctional exercises like using the tongue to press over the palate. That also we will add on.
Very interesting. So most of pediatricians here, the very interesting concept of why mouth breathing has started to increase in the population. So that is because we're not using the tongue. So this is a interesting, how myofunctional therapy works is they strengthen the tongue and the other muscles. So they're saying that the children of today, the tongue is not that strong. The buccal muscles are not that strong, which is why the mouth is being open. And the most important contributing factor is lack of breastfeeding. And they say that if the breastfeeding is there, breastfeeding prevents mouth breathing, and breastfeeding actually, I didn't put up, prevents OSA. The way breastfeeding prevents OSA is because your oral musculature and your tongue is so strong that the palate and this musculature is very good. So the chance of you mouth breathing becomes relatively lesser. The second important thing is, so as a pediatrician, of course, we recommend breastfeeding, but another take home is that we have to encourage more breastfeeding to prevent OSA today. That is very, very important. And the second thing, what happens is pureed feeds. So they say that you need to start introducing solid feeds relatively early. Make the child start chewing much faster. So what happens with children who are given, like even you hear parents say, I am still grinding the food and giving, I'm going on grinding the food and giving. If you keep grinding the food and giving and the child is not encouraged to strengthen the oral musculature, these are going to develop high arched palates. They are going to develop OSA. They are also going to develop mouth breathing, habitual mouth breathing. So in these children, we also encourage them to chew. You have to teach them to chew. Parents are like, it's a headache to make him chew. It'll take 1 hour to chew. So just grind it and give it. You'll have long-term consequences of OSA with these children.
Okay. Thank you, sir. So we'll wind up the session for want of time. Okay.
While he asks his question, I have two more points to make regarding the
Okay.
mouth breathing. When you have a child with post-operative OSA and it's still a child requires CPAP or BiPAP therapy, sometimes what we do is we also do something called as chin strapping, which helps close the mouth. Second thing is now the influencers are going to come up with mouth taping that you see online, or they're going to see nasal clips. We don't recommend that in children. We don't recommend that in adults as well, because you're obviously used to be breathing through the mouth and you're going to shut off oxygen that is coming through one source. It could be life threatening.
Thank you. So let's close the session now.
Sorry. You were talking about the inflammatory component in the OSA, which seems very fascinating. Rather, over a period of time, do you foresee a future, just as in the case of asthma or whatever, OSA becoming an inflammatory airway disease rather than an obstructive airway disease? And then how do you justify the removal of an adenoid or a tonsil for a OSA, considering that the pathology is likely to be in the retropalatal area rather than the retroglossal area?
So that's very good. So
This
that's,
is
sorry.
one.
Can I answer this? Then you ask the next one. So at least the audience don't get confused. So agreed with the inflammatory disease, a new concept, because long time, everyone, OSA means adenoids, OSA means adenoids. Of course, that is changing now. It's an evolving concept because they're now identifying the inflammatory mediators. They're isolating the inflammatory mediators. So all the adenoids and tonsils which were removed, they've studied what are the inflammatory mediators in that, and they found that all of these who had severe OSA, the adenoids and tonsils had higher level of inflammatory mediators. That's how they found out that it's an inflammatory disorder. Asthma, OSA, allergic rhinitis, we use the single airway hypothesis. All of them go together. So the studies we are doing now, what is the prevalence of OSA in asthma? 40%. 30 to 40% of asthmatics will have OSA. How many of allergic rhinitis have OSA? Almost 70 to 80% will have. Sleep disorder breathing. Sorry, I won't go into OSA because it's not done with sleep studies. So they will have sleep disorder breathing and they all are a single airway. So it will correlate. Weird factor is, what about obesity? Now all the people are saying obesity is also an inflammatory condition. So you realize all of them are going together. Obesity, OSA, asthma, allergic rhinitis. All are inflammation and they coexist with each other.
And this is just a take-home probably question. The usual routine is hypoxemia, give oxygen. will oxygen for a child with OSA be deleterious rather than a CPAP?
Yeah,
Isn't
it will be deleterious, primarily because the hypoxia here is not a chronic hypoxia. It is very intermittent. Now, see, when I say on a sleep study, what is the hypoxia I record? The criteria for us is 3% drop in saturation during that obstruction. Now, it will be weird. The 3% will be from 100 to 97. That is actually a desaturation for us in a sleep study. But if I ask you from 100 to 97, the oxygen drop, should I give oxygen? No, because it lasts for only few seconds and then it goes back. So like I mentioned at the beginning of the talk, it is not that level of oxygen is not my problem. The fact that it drops and then goes back, drops then goes back, that is happening so many times. And that is more deleterious to me than a chronic hypoxia. What is the problem with giving oxygen? Remember that what is the stimulator for you for breathing is carbon dioxide. So by giving oxygen, and hypoxia also stimulates, right? Hypercarbia and hypoxemia stimulate your respiration. So giving oxygen can be deleterious in these patients because you're suppressing the respiration rather. So in children with neuromuscular syndromes, example, so even though they have severe OSA, we don't allow to give oxygen in neuromuscular patients who are on CPAP, BiPAP. Don't give oxygen because that will suppress their respiration even further.
After any intervention for OSA, for a repeat PSG, are there any criteria apart from the clinical criteria like say snoring or anything else? Do you consider anything else for a repeat? He said 6 weeks.
Correct.
After
So all those charts, I put up one chart on what are the risk factors for residual OSA. So the risk factors for residual OSA, first is severe OSA. That means you did a sleep study before the study and it came in severe category. If it is in severe category, you have to repeat it because there's something unusual. In pediatric, we don't see such severe OSAs. So if it is in that severe category, you have to repeat. If they have any of your comorbids, obesity, you have to repeat, genetic syndromes and neuromuscular disorders. So in these patients, we repeat the sleep study after 6 weeks. If it's your regular normal child, we don't need to repeat it.
Thank you.
So put it in other words, sir, if there are no comorbidities and there is no any anomalies and AHA is not that much severe, and after surgery, if the patient is symptomless, then we don't need to do. In all other cases, we need to do.
Thank you, panelists, for an active discussion.
Good afternoon. Thank you for inviting me, Thuyil and Pixel. Generally, I'm told that the whale nets won't be able to catch the shrimps, and the shrimp net won't be able to catch the whales. I'm told here that there are a lot of first-year trainees in pediatrics as well as senior consultants. So I have mixed up the nets, and it's up to you to get caught in these nets. To start with, this is our chapel in CMC. This is the Center for Children with Neurodevelopmental Disabilities and Disorders. The talk was supposed to be on the evidence-based early intervention, which is a very pointed kind of topic. It might be a little drab for the first year PGs in pediatrics. So I have made the net a little wider, and we'll see that the first thing in India is the prevalence of autism, which says it's about 9% or even less. But across the world, we know it's far higher, and we see that in India, another meta-analysis done by us shows that it's up to 2%, which is similar to the world across globally. Now, we know up to 30 to 70% of children have a dual disability. And so whenever we see the literature, it's never a pure intellectual disability based study or a pure autism based study. It's a combination of both. கேக்குது கேக்கலையா கேக்குது close. Okay, thank you. So most of the studies, most of the clinical programs, standard ones, are designed to handle this dual disability. Now, we all know about the evidence-based the evidence pyramid or the different levels of evidence. Now, what is the problem in following strictly the evidence-based pyramid, based evidence in this talk, is that you'll see when you're handling with dual disability, there is a communication problem. The children won't be able to communicate exactly what they have in mind. Secondly, when you are doing a study like a randomized controlled trial, we are going to find it difficult to mask the child, randomize the child, or the spillover effect. When we are doing a non-pharmacological techniques, that's going to be my primary talk, you'll see that a lot of parents share with each group what they have learned in that particular arm of the randomized controlled trial. So you'll see that there are also spillover effects. So this is not something that strictly can be followed when we are doing studies with children with dual disability. And the pyramid that we generally speak about is the, usually see is the intensive intervention, but the intervention intensive alone won't be able to take care of the children with dual disability. Therefore, we have to generate in India a whole ecosystem which goes from the base where the society comes in, followed by the school systems, and finally the healthcare systems. Now, looking at the evidence base, this is what everybody accepts, and therefore I'll use that as the common evidence-based template to discuss things in detail. The first one is that we know if we give early intervention for children before 2 years, there will be a long-term positive effect, both in their skill deficit as well as their symptom severity in the triad of autism. Now, when we do an early diagnosis, that is what both the WHO and the different guidelines suggest, you will see that unless you have a measure with good diagnostic accuracy, we are not going to be able to get a correct diagnosis with early, especially under children too with ASD. Thirdly, in our country, what is not found to be in use or not in vogue is the evidence-based structured intervention protocols, and finally, the consistent follow-up. Most often, we lose the children after a couple of years after the training. So there is a problem in the follow-up also. Again, we know that there is a regression, which is a challenge in these children with ASD and dual disability around 2 years of age. And what is the most significant and important scientific knowledge that we are gathering is, once you diagnose a child with ASD, it's not always that the child will continue to have autism. There is more evidence coming in. So even DSM-5 was dilly-dallying with the idea whether we should have really autism in remission. So how does it happen? Autism, can it remit? We will see later on as we progress. Generally, if you want to cover the whole ecosystem that is needed for children with autism, you'll find that there are 5 axes we need to cover. It's not just the tip of the pyramid, as I mentioned. So what you'll see is, if you can, below 2 years, hit the base of the pyramid, the whole prevalence of autism can collapse. That's an important date that's gathering now. So focus is below, you see the widest part of the pyramid, under 5 years, that is our area of intervention. The second important thing that has happened in India is, when we were being trained, there was no specific measures available in India to classify children of different severity. But now, over the last 20 years, you'll see that both the early MCHAT and the RBSK tools have been validated and standardized for India. And even if you want to follow up and do comparative studies with the uh, global research, you'll see that in India, we have CARS and a whole lot of other tools that have come up. Remember, these tools are going to be the building blocks for the next generation of research in early autism. So what is this multi-axis diagnosis I spoke about? The first axis we need to kind of address is the ASD severity and the challenging behaviors. Both have to be handled side by side. Axis 2 is the etiological workup. Axis 3 is the physical comorbidities. Axis 4, the psychiatric comorbidities. And axis, an ever-increasing circle of psychosocial issues. So what is this axis 1, severity and the challenging behavior? How do we now assess and give this therapy to the children? Remember, even though we have about 9% of children with autism in India, still that healthcare for this population is not organized by the government. So still, it is the private sectors which are taking care of the children with ASD, and the skill building is therefore through the families, especially the parents, which translates to 99% of the time by the mother in India. Also, the caregiving population is skewed geographically. Most of the child-related mental health people are in cities. There are not many facilities that enroll children with dual disability, and they do not follow established protocols. As we saw in the morning, when there were head and neck specialist, ENT, pulmonologist, pediatrician, each one with their own guidelines, there's a lot of difference. So you'll see the same difference in the various guidelines put up for the autism by the different specialties. However, I'm not going to stick to any particular guideline. It is the overall research that shows what works. A lot of people believe one-on-one therapy for speech, one-on-one therapy for various other things help children with autism. But you'll see against that, it is the small groups of children and their parents, they do better than one-on-one therapy. I spoke about the structured assessments, and I told that there is always a dual disability. You are not going to see intellectual disability or autism alone. So this is an assessment, which is a North Carolina program, but it is very well Indianized. We can use it, is for the intellectual disability. Here the child came in with the orange skills, then with 3 months of intensive intervention, the child has continued to progress in the intellectual disability. You'll see, as the age goes up, we can have other structured programs to improve the mental age of children with intellectual disability. Along with that comes the typical standardized intervention protocol for children with autism. And one of the standardized protocols we find and is useful is the psychoeducation profile revised. So this will clearly tell you how much the child is progressing with each of the 3-month visit. So you can see the first one was when the child came in to our facility. The pink one was after 3 months, and then the purple one. So the child continues to grow despite autism and intellectual disability. When two of these different standard programs are combined, this child has gone up from 1 year, 4 months to 3 year, 4 months. That's in about 6 months' time, which is a giant leap, because what we see is generally a school child in 1 year will be able to garner 1 year of knowledge. So when you see a child with dual disability, when you use very structured protocols, you'll see that the child can gain more than 2 or 3-fold of intellectual capacity. So we can classify the interventions for the dual disability as high intensity. What we do, for example, is a high intensity. The child gets 2+ hours of therapy in group settings, in individual settings, then they have a home training program. So that's a high intensity, and you will see that this is the significant column where all the severe and the mild children gained in the different domains. So imitation is, for example, a problem with children with autism. You can see despite the severity, both children with mild autism and severe autism, when I talk about severe autism, these are children who have profound and severe ID, you would have seen in your practice, with all kinds of movements, stereotypic movements, the restlessness, the overactivity, they are all over the place. So despite their severity of both intellectual disability and autism, they show improvement in all these areas. Now, if the child is not able to get a high intensity intervention, then the studies we did with low intensity, you'll see the low intensity clinical intervention. So the child has got about 30 minutes. This is elsewhere, not in our center, but we are part of the study, where you'll see when we use the childhood autism rating scale as the outcome measure, you see that almost all domains improved. The same thing you'll see that if you do a low intensity home intervention, still you see the benefit. So the most important thing is, if you don't have a high intensity facility in your area, doesn't matter, give a low intensity or even a home training program, the child will show some gain in their skills. You don't have to wait for a high intensity program to happen. Yeah. Now, what are the global thoughts on this? A little bit of what one of the major systemic review and meta-analysis shows. This is one of the best studies till date. This is from the Cochrane review, and many studies have replicated this. And many studies before that also have replicated this. And till date, the findings of the study has not changed. So what does it show? It shows that if you give the EIB or the early intervention, that's towards the right, and the treatment as usual is towards the left. If you give an early intervention before 2 to 5 years or before 3 years, then there is a substantial gain in children in their daily living skills or the adaptive behaviors, quite significant, up to 10 points in the effect size. Now, coming to the socialization, because we know one of the core problems of autism is the socialization, communication, and the repetitive and the narrow repertoire of behavior. So if you see, there is socialization some scale in the adaptive behavior also increases, significantly with the early intervention. So your adaptive behavior changes, the social behavior of a child with autism changes. Now, the clinical severity, that also favors the early intervention group. So all the self-injurious behaviors. So we know a lot of syndromic children, ASD, they'll have something like Leschnihan, where they'll have severe self-mutilatory behavior and so on, which will need a pharmacological approach. In addition to that, we can give behavioral approach, which together can contain it quite significantly. So looking at the type of self-injurious behavior, we can identify which neurotransmitter is affected. So remember, when you have an early intervention program for all the clinical symptoms, you have a substantial gain for the early intervention group. How about the intelligence? So when we talk about intelligence, we always believe that it is a constant. As the mental age is increasing, the chronological age is also increasing. So the gap remains the same despite the increasing chronological age of the child. But you find that when you give early intervention, even the intelligence has the potential to improve. So catching them young, catching them before 3 years is of absolute importance. Language and communication, the most difficult of all areas. This is what the parents will come to you for. My child is not able to respond to me, bond to me, communicate to me. And you will see that against the treatment as usual, the early intervention has got a significant effect on the early interventions. Now, I'll skip this slide. I'll be repeating it again. Academic placement. What is that we have? We have actually no study across the globe if these children are academically placed in the mainstream education. Parental stress, this is important. You will see that the treatment as usual have got less stress. Parents who got early intervention had stress more. So we did a similar study where we found the same thing. At the end of the 3 month stay with us, the parents became extremely anxious. So when we went out with a qualitative study, the finding was that the parents knew the diagnosis of the child, the parents knew what to do, but the parents did not have time to do that. So that made them extremely anxious. So we had to, in our own protocol, build a time management plan for the family, especially the mother, to use that. So it's the same case here also. You will see that the early intervention can sometimes cause anxiety in the parents unless you find what is happening and how do we do away. Now remember, in India, 90% of the time or 99% of the time, mother is the binding force, right? So it's especially so in a special family where there's a special child, and if the mother snaps, then the whole family snaps. So it's very important that we look at what the mother is capable of doing, and then we slowly build in the support around her. Challenging behaviors, when we did that, the problematic behaviors is one which takes away the hope of the family members. It's not actually the child is not talking. The child not talking, or sometimes the comorbidity not able to walk with a hypertonic kind of a situation, that worries the mother. The burden is up, but the hope is lost when the child has got significant challenging behaviors or problem behaviors. So what do? We use the differential reward technique. Basically, a differential reward technique can be put like this. If we want to stop a child from spitting, reward the child when the child is not spitting and ignore the child when the child is spitting. So over time, our plasticity happens in such a way, the rewarding happens in such a way, the collateral neurons are recruited in your brain, and the tract for no spitting gets strengthened. And when you ignore, like the disuse atrophy, they both are what do you call Nobel laureate work. One is the disuse atrophy, the other one is the collateral Hebbian recruitment. You can weaken the behavioral problems with that. But as a pediatrician, if you are going to see a child who is going to sit and bang the floor, bang the head on the floor, then you are going to have a visceral response from the parents as well as people around. In that case, don't bother. You can conveniently you can give 0.125 milligram per day of risperidone for children under 5, right? So again, it comes with all the endocrinal issues of weight gain, dip in prolactin as they get older. All those things are going to happen. You have to keep an eye on that. Do we have a structured way of assessing that in India? Yes, the National Institute has brought out a way of assessing the different types of challenging behaviors in these children. I spoke about the importance of a structured assessment. This is important. So how do we now measure the mental age of a child who is not communicating? So very often we see in our center children who are severely intellectually disabled and severely autistic. So they are not verbal, they are averbal. So there is another way we have uh, kind of validated and published. Using the psychoeducational profile, we can also get to know the intellectual ability of the child. So there are ways of understanding a child's ability despite both the disabilities. Now, Axis 2 is the etiological workup, which is the major area for pediatricians. But I would caution like this. We generally provide if the family is not complete, right? And if you or the family needs agentic counseling, ask for agentic counseling, please go ahead and do that. Why I say this is often it's a wild goose chase. Interventions are not etiologically based. None of our interventions are etiologically based. So if there is a Prader-Willis child who is going to eat a lot, it is not based on the diagnosis, the genetic diagnosis. It is going to be most on the behavioral techniques, right? So sometimes the interventions, or most of the time, interventions are not etiologically based and they are still prohibitively expensive. We get children from the West Bengal, for example, they would have sold their utensils and their cattle. They would have come all the way to CMC hoping that there will be a cure for that. So I would discourage that kind of behavior in trying to find out the etiology. Pediatricians, please remember you are the gatekeepers. So keep in mind what the family can do for this child. Physical comorbidities, again, the pediatricians are the ones who take care of the CP and the epilepsy and special sensory handicaps. Now that we have a developmental pediatrics department, the next speaker will be talking about that also. They take care of these physical comorbidities or the axis 3 of the children with ASD. Now, axis 4 is the medical comorbidities I spoke about. A special mention is important for the obesity setting in around 2 itself. If the child is going to be on a low dose of antipsychotics, or even by 4 to 5, even without medication, we see the obesity coming in. Could be syndrome. Now, not related to the medical comorbidity, but usually in India also, by 7 years, something happens, and that is when the families split. The marital disharmony sets in by 6 or 7 years when a child has got a special need. So one has to keep in mind and look out for that. Is there a rift that's happening because of the child? Sometimes they break, sometimes they bond the parents. Psychiatric comorbidity, the one to write home about is the ADHD. Rest are all small comorbidities, but ADHD is the major one when you take a psychiatric comorbidity, and you can again use a structured way of assessing that. This has been validated for India, so pediatricians can very easily use this. Conners is a very long scale, and this is a short scale with different cutoffs for girls and for boys for evening and morning, because ADHD patterns can vary throughout the day with the circadian rhythm also. So this can be used. And if the child is accident prone with autism, ADHD as a comorbidity or a major symptom, then you can use tablet atomoxetine 0.8 milligram per kilogram body weight as the top dose. Psychosocial issues, it's as I told you, it's an ever increasing concentric ring of problems we have to handle. The first one is the knowledge on child rearing, and especially children with neurodevelopmental disorders. Attitude, very often you'll find the attitude of the parent towards the child is very positive and they are overprotective, or they are negative and outwardly rejecting. And therefore, there might be a need to balance the attitude of the parents to get on with the different interventions. Expectations from the child with ID, high expectations. Grief. Grief is a major issue. We'll come to that a little later. Burden, self-support groups, and continuity of the care has to be kind of improved in our culture and country. Now, one of the ways we can overcome many of the problems associated with the parents and their uh, families is having an interactive group psychoeducation. This is very easy to do. This is only 4 steps. You don't have to invest a lot in psychotherapy and so on, but the 4 steps can make a big difference. One is a didactic component. The person first informs about, for example, what is the difference between autism and intellectual disability, or what is a mental illness from autism. And then there is a small group discussion among the parents. Then the group solves the problem. If it is not, the therapist suggests solutions. You find that this 4-step kind of a therapy takes care of a whole lot of family and parental issues. And this is one of the RCTs that we did uh, in using this 4-step method for improving the parental attitude and knowledge towards autism and ID. The fallout of the improved attitude and knowledge of the parents is it reflects on the improved adaptive behavior of the children who have got ASD and who had the parental attitude therapy, and not the ones who didn't get the parental intervention. The role of gender, this is important. When I said around 7 years is when the parents go for a split, we found out that it is not all parents. The highest risk factor is when a girl has a autism with ID, is when the parents fall apart. So if you are going to see a child with the ASD ID and the person seems to be a girl, not seems, is a girl, then you have to be extra careful about the family's functioning. Burden of care, you will see the burden of care compared with autism and intellectual disability, and intellectual disability alone, is that the dual disability has got, it's not a rocket science. We know the burden is high when there is a dual disability. Breaking the bad news, parents must be told as soon as possible. We see children 8 years, 10 years, 12 years, still the parents haven't been told, or the parent hasn't told the child what are the steps they are going to take to improve the situation. Parents should be always told together, because we know always there is, almost always there is a blame game that starts. Which family is responsible for this? The child also should be present and convey the message that this child is still an important member, is a spoke in the wheel. So sometimes we add the child into what the family is doing for a living, and therefore a person who is considered as not so important becomes a very important member to bring in money into the family's kitty. The discussion should be private, we know all that. The news giver should be a well-informed person. That's important, because long ago, when children were in pediatric ICU, were struggling to survive, we would be called in suddenly to break the bad news. The best person always is the pediatrician who has been doing the primary care support. It's so easy for the pediatrician to break the bad news than bringing anybody else to do that. So if you have been caring for this family, from antenatal to neonatal follow-up and so on, you might be the best person to give the bad news to the person. Grief. Now, grief is always a one-time event. So somebody passes away, and with that event, you come out of it gradually. So it's a normalization process, grief. We all go through that. But remember, in a family with a child with a special need, this is a recurring grief. So you can't settle it that easily. So when the peer group of this child is starting to speak, the parent goes through grief and the child doesn't speak. When it's time for the child to go to school and the child doesn't, the parent goes through grief. So it is a recurring grief, and you'll have to have a long-term support for the grief of the parents. What are the barriers to the family's intervention? It is the fatalistic attitude, poverty in our country, lack of awareness, skewed distribution of resources. With that, I'll say that take-home points are most early interventions you see in the literature are not for ASD alone, it's for the dual disability. Measures are now available in India, which were not about 20 years ago. EI can easily disturb the prevalence pyramid for ASD. Organize the clinical care in a multi-axial approach. Don't give the peak of the pyramid alone approach. It's not going to help the family or the child. If high intense intervention is not possible, go for a clinic-based low intervention or a homely based low intervention training. Self-injurious behaviors and ADHD overactivity, primary will need medication when the child has autism and ID in the background. Use parents for the interactive group psychoeducation to support the family and the parents, plug them with the support groups and the government programs. With that, I'll end my talk. I'll take up if there are any questions.
Now I'm going to talk about a very necessary evil, which is the screen time. இது இல்லாமலும் இருக்க முடியாது, அது இருந்ததுனால தொல்லையும் கண்டிப்பாக இருக்குது. ஸோ கல்யாணம் மாதிரி. ஸோ navigating digital media in early childhood. So we are going to see a basic this thing for pediatricians. How do we help parents manage screen time? Outline of today's talk is just going to be on what is the impact of screen time on early childhood. Why early childhood is a very critical period when it comes to screen time. And the next half, we are going to see about the problem statement. How big is early screen time a problem? And we also have to understand what parents think. It's easy for us to advise that screen time is bad and you should reduce screen time. But பேரண்ட்ஸ்க்கு தெரியாமல அது யூஸ் பண்ணுறாங்க. ஸோ வை டூ பேரண்ட்ஸ் ஸ்டில் ரிசார்ட் டு ஸ்க்ரீன் டைம் டெஸ்பைட் நோயிங் ஆல் த ஹார்ம்ஸ்? வில் ட்ரை டு கெட் அ picture about that. And finally, we'll conclude with what are the ways forward? What are some actionable goals which we as pediatricians can go back and start doing? So to start with, what is screen time? Any time that the child spends in front of a screen is screen time. அது கம்ப்யூட்டராக இருக்கட்டும், டெலிவிஷனாக இருக்கட்டும், or 70 mm screen இருக்கட்டும், the screen size doesn't matter. If it has a screen, it's screen time. And what is the difference? We must understand the difference between active and passive screen time. What is active screen time? Any screen time where the child has some engagement or some interaction with the screen, whether physically or cognitively, is active screen time. Example could be online classes, or child learning art or craft activity, or child learning some fitness exercises from the videos. All those are considered as active screen time. But what is passive screen time? Where the child is not required to interact either physically or cognitively, is passive screen time. And it is this passive screen time that is more of harm to the child's development.
Now, going ahead to understand why early childhood is a very critical period, we all may know 80% of adults' brain size is attained by the age 2, and almost 90% is complete by the time the child is around 5 years of age. And there is also a sequence by which these pathways develop in the brain. If you can see here, first, the vision and hearing pathways are myelinated first and they develop first. Then the language pathways develop, and then only the higher cognitive functions develop first. This is very important for us to understand the impact of screen time in the coming slide. Now, why is it important for a child to have a human interaction? Many studies have been done about early childhood development, and they have found out that it's a complex interplay of gene and environment which fosters the brain architecture. Both are important, the genetic component as well as the environment component. And among the environment component, the major ingredient is the serve and return relationship between the child and the parent. Why is it called serve and return? The child reaches out for interaction through babbling, through facial expression, and through gestures to parents, and the parents have to respond back to them. That is serve and return relationship. And this ingredient that is very important for the basic architecture of the brain to form. And it is proven well beyond doubt that absence of such responses in early childhood, the brain's architecture does not form as much as expected, and that results in disparities in development and behavior. So the timing is very crucial. We are all well aware of the neuronal plasticity. Brain circuits become increasingly difficult to alter over time. So in young childhood, when the brain networks are still being laid, early plasticity period, it is easier for us and it is very effective when we intervene and make this brain architecture optimal. Later on, to rewire the brain that has already been laid may be a very daunting task. So for optimal development, the conclusion is what? Responsive caregiving and positive learning experiences at home in early childhood is very, very critical. Now, having understood these, how does screen time impact all of this development? So I'm going to give this across a lifespan from infancy to toddlerhood until adolescent. The first impact, as we know, is on language and social communication. Some of you asked, we see a lot of children with the screen time. Is there a relation between screen time and autism? You'll get an answer in the subsequent slide. Prolonged screen time has been found to be a risk factor for delayed language development in early childhood, well beyond doubt. Why this happens? Because screen displaces human interaction. There is a displacement of rich, responsive, and dynamic live human interaction, which is very necessary for language development. Screens cannot replace this live interaction. Therefore, whatever is displaced, it results in impact on language. Screens also reduce the quality and quantity of interaction between the children and their caregiver. Please understand, this is not only the child screen use, the caregiver screen use as well. So 2 or more hours of screen time daily results in poor vocabulary acquisition and an overall language delay. Not only that, if the child is reared in an environment where TV is running passively, a passive screen exposure, background screen exposure, longer media exposure, even presence of television in the child's play area or bedroom has been found to cause interference in language acquisition, especially delayed receptive language skills. And this is called as technoference, technology interfering with development. So this is very much known. This is the language pyramid where a child first has to look and listen to the people around, then child will make effort to engage with people around through social play, then child tends to understand what is spoken, and then finally child starts talking. This is the pyramid of language acquisition. Child has to have an intent to communicate for the child to develop language, and screen devices definitely interfere the progression of the child up this pyramid. And what do studies say about screen time and autism? Community-based studies, large population cohort studies have proven that there is 3 times increased risk of autism among boys who are exposed to screen time in younger ages later on in life. 3 times in boys. Does that mean girls are somehow better protected? No. What they found, the studies so far have included far little number of girls that this trend could not be appreciated. There was a trend, but it was not statistically significant because there weren't much number of girls with autism that were diagnosed in the cohort. These cohort studies are ongoing. So what is very important? Longer screen time at 1 year of age significantly associated with autism. Remember, there's a difference between association and causation. A causal link is yet to be proven. And there have been hypotheses about screen time's causation in autism. What do they say? A genetically predisposed child, a child who has genetic or epigenetic alteration, can predispose to social communication delay. When they are exposed to early life's non-stimulating environment, like a lot of screen time, very limited parent interaction, what happens? This child develops a lot of non-social audio-visual processing area. Rather than social circuits developing, these child develop non-social audiovisual processing area circuitry develops, and thereby it results in a negative impact on the social brain and cognitive pathway. This is the hypothesis. And early intervention, that is when you intervene early, you break this cycle and thereby result in better improvement of the social brain and cognitive pathway. This has not been proven by imaging or other studies thus far. So this is a hypothesis that was proposed by Heffler and team, but this is very much plausible. And going on to, we saw the effects on language and social communication. Now, what are the impact on cognition? All areas of executive functioning are affected by screen time. It affects the child's attention. It affects child's working memory. It affects impulse control in toddler. Early screen exposure can have negative impact on cognitive ability. A Canadian study showed it can result in very limited classroom participation, up to 7% decrease, and a 6% decrease in math proficiency as well. So screen time at age 2, poorer cognitive outcomes and executive dysfunction. And social emotional development, again, a child has to learn social cognition from observing the people around. When screens distract the child away from the social environment, definitely it results in poorer social emotional development. It's very much plausible. What happens? Detrimental effects have been proven on social emotional growth. It interferes with the child's ability to interpret emotions. It fuels aggressive contact. Children with a lot of screen exposure have an inherent aggressive nature to them. These children are less curious, they have very limited self-control, and they also have a lot of emotional instability. And it is very negatively associated with self-regulation. Haven't you noticed parents, whenever the child cries, immediately they try to distract them with the screen? What happens? That interferes with the self-coping mechanism development. Thereby, when the child grows up to be an adult, it creates a dependency on an external stimuli to soothe him down. The child cannot console himself. Child cannot take no for an answer. Child cannot tolerate failure, all those. So it prevents formation of healthy internal coping strategies later on. Now what happens in school going age group? சரி சின்ன வயசுல தான் காமிக்கூடாது, பெருசானாலாவது காமிக்கலாமா அப்படின்னா what happens? In school going age group, children who see a lot of screen time, especially children who resort to a lot of gaming, what happens? Higher level of dysregulation, lower mathematics and literacy grades are observed by age 8. And again, it has a huge impact on executive function. Executive functions are like the air traffic controller of the mind, of our brain. Whatever comes in, whatever goes out, it has to be regulated. It's like a filtering mechanism for our brain. And higher screen time has been linked to ADHD. Again, not causation, has been associated. And consumption of adult-oriented and older child-oriented content leads to a lot of poor pragmatic skill. சின்ன வயசுல அந்த குழந்தை பெரியவங்க மாதிரி பேசச்சே சந்தோஷமா தான் இருக்கும். People may laugh around. But imagine when he goes on to become 5-6 years and talks like an adult, sometimes it can get very uncomfortable. So it leads to a lot of poor social use of language, which is called as poor pragmatic skill. And gaming is related to poor emotional understanding, especially in boys. And adolescence, what happens? Screen time has been linked to development of both internalizing as well as externalizing problems in adolescence. And what do they resort to? To cope up from these problems, again they resort to screen time, and that results in a very detrimental feedback loop. And excessive social media use leads to increased rates of depression, feeling of social isolation, and exposure to cyberbullying among adolescents. So right from childhood, right from early infancy until adolescent, uniformly screen time is known to have a lot of detrimental effect. Now, one of the myth that which parents quote, saying that adha paatha kulandhikku buddhi valarudhu, educational apps, that's what they say, no? That is one of the people say that is one of the uses of screen time. Is it a myth or is it true? It has been proven well beyond doubt that children learn better from persons, interacting with persons or through real life experiences than the video content. This is the video deficit hypothesis. So what he learns from screen, is definitely far less than what he learns from real life experiences. So again, this myth also is busted. So there is no truth in educational content or learning apps. So what are children actually learning from observing screens? They may only be learning skill and drill concept. Anything that can be rote learned, they can pick up from screen. They can pick up letters, they can pick up phonemes, they can learn vocabulary from screen. They may understand idea about situations, all those. These are some things which screens can give. But will it be applied in real life? It's a question. Will they have creative problem solving? Absolutely no. Can they do multitasking? Will they have better attention span? Definitely no. And can they be better emotional, empathetic humans? Definitely no. Having idea of social situations alone is not enough. How to respond to these social situations, they learn only from real life experiences. Again, when it comes to language, children may say a lot of words, but they may not know how to use it or when to use them. So increasing vocabulary does not necessarily mean better language skills. That also is a big question mark which children learn from screen. Now, what are the other effects? காலையில ஃபுல்லா sleep பத்தி பார்த்தோம். So again, one slide on that. It definitely results in sleep disruption. The blue light that is emitted by most of the screen devices, it mimics daytime, and that suppresses melatonin and it desynchronizes the body's natural circadian rhythm. And high arousal, so the screen content keeps the child stimulated, and this screen content will prevent deep sleep in the child. Not only that, many parents use screen for pacifying the child. தூங்கவே மாட்டேங்கிறான் அப்படின்னு ஸ்க்ரீன் காமிச்சு தூங்க வைக்கிற பழக்கம் நிறைய பேரண்ட்ஸ்க்கு இருக்கு. Is that correct? No. Sleep problems, 3 to 5-year-old children who are exposed to screen during the evening hours. Remember, this is not before sleep. Even showing screen time in the evening hours resulted in later bedtime, increased bedtime resistance. So சாயந்தரம் காமிச்சாலே நைட் எஃபெக்ட் இருக்கு அப்படின்ற போது தூங்கச்சே காமிச்சா absolutely it is counterintuitive. So using phone to make the child sleep sounds counterintuitive. Another physical impact, we all know that green time spent outdoors, time spent amidst green nature is a natural mood enhancer. It improves serotonin production. It is an attention restorer. And resorting to screen time results in reduced exposure to green time. Thereby, it also affects the mood of the person. And one of the most important impact of screen time, which indirectly impacts development, is obesity. The physical health of the child also has taken a big beating. And it is because of this reason that screen time has become a global public health problem now. School children, preschool children linked to school screen time, 1.5 times higher risk of obesity. 1 hour increase in screen time results in 10% increase in obesity risk. What is the reason? Physical activity is displaced, and thereby it also negatively impacts the bone health as well. Not only that, viewing screen, advertisement and all are about poor diet choices. So naturally child will be eating wrong as well, and it also disrupts the sleep of the child. Why as pediatricians, why as future health professionals practicing in India, it is important for us to know we are becoming a global leader in obesity. Idhula aramo illiyo, idhula we are definitely on the path. By 2030, 1 in 10 obese children will be from India. And what are the reasons for increasing obesity prevalence in India? One of the primary reason is aggressive marketing of unhealthy option. So நம்ம டிவி பார்க்கலன்னா அட்வர்டைஸ்மெண்ட் பார்க்க மாட்டோம், அட்வர்டைஸ்மெண்ட் பார்க்கலன்னா இதெல்லாம் வாங்க மாட்டோம். So naturally they are all indirectly linked. Increased screen time, only around 20% of Indian children meet the WHO recommended physical activity levels. That is alarmingly low. And what happens to a screen distracted child? Many parents say TV காமிச்சாதான் சாப்பிட்றோம். Correct? Common things that we get to hear. நீ சொல்லுவியா ஸ்க்ரீன் நிறுத்திட்டு எப்படி அவனை சாப்பிட விட்டுறது? That's what most mothers ask. No? What happens to a child who is fed when he is shown screen? 2 to 3 times more dopamine release than either activity alone. Screen time also gives a pleasure. Eating also gives a pleasure. When a child does both of them together, there is a high dopamine surge which can result to addictive behavior. So what happens? Child consume 15% larger bite. They don't munch well. They chew 42% less. And there is 27% reduction in satiety signal. They are not even aware how much they are eating. So it's a non-mindful eating. And this is a very good term in Japanese, very kuchi shabishi. What does that say? Sometimes when we watch screens, we just eat summa. Our vaayku bore adikudunnu nariya saapidom illaya. So screens promote comfort eating just for the sake of boredom. We are not hungry. We all eat only when we are hungry, but when we watch screens, we eat just for the sake of eating, and that again adds to obesity. All those are indirectly linked to screen time. Not only that, screens in parents, does it impact health of a child? Yes. How many of you are aware of the term Amul baby? தமிழ்நாட்டில் இட்ஸ் குவைட் பாப்புலர் இல்லையா? ஒரு குழந்தை கொழுகொழுன்னு அழகாக இருந்தால் தான் ஹெல்தி அப்படிங்கிற கான்செப்ட் இருக்கு. திஸ் ஹாஸ் பீன் இன்கிரைன்ட் பை ஸ்க்ரீன் அட் ஆல். யூ நோ ஹூ திஸ் பேபி இஸ்? This is the sister of our Shashi Tharoor MP. This is his sister. He was photographed by a photographer who's their family friend, and she vouches that she has never had Amul spray in her life. But she acted in that Amul sprays advertisement, and this was the TV ad was there, and that created an impact in people's mind as how healthy a baby should appear for a child to be called as healthy. This is just playing with parents' psyche. So what happens? Aggressive marketing leads to parental behavioral changes. We are what we consume, what we eat as well as what we read. When we read right, we act right. When we read wrong, we act wrong. So unhealthy food practices, unhealthy child rearing practices, all those can be impacted by screen as well. So are there any biological basis to all this? Does screen time alter anything in the brain? There are a lot of changes in the brain that happens. One of the most important one is the reward system desensitization, especially gaming. Gaming causes significant release of dopamine. The reward pathway is stimulated. Initially, this experience is pleasurable. But what happens? Chronic overuse when it is happening, it results in desensitization, and increasingly more stimulation is needed to attain the same level of high. And that results in poor functioning. That can result to lack of focus and lack of motivation as well. And it also induces stress reaction. The flight and fright reactions are stimulated, results in increased cortisol, and that leads to natural irritability. Many children who see a lot of screen time are inherently irritable, and later on they also develop depression. And the sensory overload that is associated with screen gives a lot of high rapid visual input. What happens? That leads to a very fragmented attention to a child, and thereby that contributes to poor focus, which affects the executive function of the child. And this has been proven by EEG studies as well, where higher theta beta ratios associated with the increased screen time, that leads to a very less alert state. Irukka ana anga illa. So linked to inattention and problems with executive function as well. Now, how big is a problem screen time? Is it there only in high income countries or low income countries? What does this say? Unlike other things, screen time is a leveler. Idhula vandu high income countries kum low income countries kum perusa vyathyasam illa. Both of them are very similar. Both high income countries and low income countries, screens are introduced before age 2. Globally, this trend is true. 0 to 2 years of age, approximately 2 hours of screen time per day, 49% of the screens being the smartphones. And in US, UK, all this data, it shows that there is increase in screen use. In fact, world over, 42% of children less than 8 years of age have their own screen device. And Indian data, not very dissimilar. Only difference, other countries, television and others are the larger one, and numbering on the smartphones. We are very smart. What is the problem with smartphone? Individualized, portable, and less supervision. What he is seeing, how much he is seeing, there's no control over it. That is even more a problem. And India, the screen time introduction, average time of introduction of screen time is 10 months, and as early as 2 months screen time is being introduced. Amma appa mohan theriyadhukku munadiye avanukku phone kuduthirranga Indiala illaya. So 15 to 18 months of age, 99.7% of children are already exposed to screen based media, and 2/3 of Indian families switch on TV during dinner, and that results in significant background screen exposure as well. And world over, this trend is true. How can we know it? These are some of the most watched videos all through the world. Top 10 la bata first in a baby shark dance. I'm sure all of us must have heard it. And the third one is Wheels on the Bus. Look at the number of views, 15 billion views and 7 billion views, all those are there. So 5 out of the top 10 most watched videos around the world are rhymes and kids content. And most watched YouTube channels, if you see, number 2 is Cocomelon. Inga Cocomelon theriyadavanga irupangala. And Kids Diana Show. These are kids creators themselves. There are kids who create content here. Kids Diana Show, Vlad and Nikki. So again, top 10 6 are children related video content. I'm sure parents are not watching it. And இப்போலாம் வந்து ஓபிடியில் நம்ம வந்து ஹியரிங் டெஸ்ட் பண்ணணும்னா what do we do? Yeah, somebody guessed it right. The audio is not playing, sorry. The Cocomelon tune. The moment you put Cocomelon tune, திருப்பி பார்க்க மாட்டான். அந்த Cocomelon tune பார்த்தோன்னே அந்த வடிவேல் ஓடி வர மாதிரி அந்த பிள்ளை எங்க இருந்தாலும் ஓடி வந்துடும் இல்லையா? Yeah, playing now. So the moment this tune is on, attention is grabbed. So that much is screen addiction or screen dependence on children. So now, why parents resort to screen time? Is 5 more minutes. So despite adequate awareness, I'm sure most parents are aware that screen time is harmful, but still, why do they resort to it? What do studies say? Many parents feel it is educative. Many parents feel it is a safer alternative. And it's a common time pass for parents themselves. They have nothing else to do. So what else can we do? Those are some of the things which parents say. That is one of their perception. The other things are societal pressure. நான் என் குழந்தைக்கு நிறுத்தி வைக்கிறேன், எங்கள் வீட்டில் காமிக்கலாம், நம்ம பக்கத்து வீட்டில் போய் பார்க்குறோம். That is again a common explanation. And many parents believe children may not get harmed by screen time. Everybody is seeing what is going to happen. That is another reason they say. And no alternative strategies. Nothing else is there. What else can we do? And what are the factors that influence screen time? One of the most important factor is parental screen time and parental perceptions about screen time and having screen time during meals. Other ones are children's ownership of an independent equipment. These are some of the easily modifiable strategies which you have to have in mind if you have to reduce this burden of screen time. And research synthesis from India. Why do Indian mothers introduce screen time? It is often during complementary meal time that they start screen time. They use screens as an appetizer because parents prioritize making the child eat on that day and managing the behavior associated with meal time on that day rather than long term effect. அப்புறம் உள்ளது அப்புறம் பார்க்கலாம், இன்னைக்கு சோறு சாப்பிட்டா போதும். That is what parents say. So as pediatrician, what we have to remember is the focus of our communication about screen time should be to first time parents because they are most likely to introduce screens to their child during meal time. So we should spend additional time in anticipatory guidance of this subset. And the Indian mother, the poor Indian mother, and India, responsibility of feeding a child is solely placed on the mother. There is very limited support system. Mother blaming is very common. குழந்தை ஒல்லியா இருந்தா ஏன் சரியாவே சாப்பாடு கொடுக்கறது இல்லைன்னு everybody comes and inquires the mothers. How many of you parents here have faced this? குழந்தை வெயிட் போடலன்னா people come and ask, correct? So the blame is always on the mother. Larger family sizes, working mother place additional burden. So there is no sufficient time for the mother to engage with the child and feed the child, take time to do. So screens offer an easy way to out of this stress. So they can cope with their stress easy. It reduces their workload and it is convenient. So when we work with Indian mothers, we should adopt a nuanced approach so that the social cultural dynamics that we have discussed so far should be factored into the guidelines. So way forward, what we can do as policy makers, public health campaigns on ill effects of screen time is urgently needed. And promoting outdoor play area, especially in town planning, creating safe play areas in residential areas is very much. இடம் இருந்தால் அதை வீடாக மாற்றிடுறாங்க. ஸோ there's hardly any place to play for children now. And it is time that we all thought of curb on content for the creators and screen use among children. Having statutory warning before every kid's content also, if it may help, we should definitely seriously consider it in the coming days. And what can schools and teachers do? Rather than giving lot of project work for the kids and make parents do, they can consider homework for parents based on screen-based activity. Parents have to play with their child and send videos or photos back to school. That is one option. There are a lot of traditional games which can be played within the confines of a home. These offer very good screen-free alternatives. And as pediatricians, what should be our content of anticipatory guidance be? First, responsive feeding. No screens during meal time. Sit and talk to your child when feeding, and screen dieting for the family. An extended family should be included when we give this feeding advice. Awareness video about ill effects of screen time, especially about mindful eating and harms of obesity, all those should be told to the parent. Avoid using screens as pacifier, and mainly say parents that saying English rhymes or words does not mean child is intelligent. வார்த்தை சொல்றதும் வார்த்தை தகவல் பரிமாற்றத்துக்கு பயன்படுத்துறதும் completely different. So child who says 2-3 English words does not mean is intelligent. So screen is not much of an educative value in early childhood. And other child psychiatrists and child development professionals, what we have to do, incorporate digital media screening into a routine well child visit. Development also should be followed up, and we should routinely keep asking parents in each well child visit, each follow visit, about how much screen time they are using. What all we should ask: are you using screens? If yes, what are the devices that you use? What is the quantity that the child watches? What is the content that the child watches? Do you co-watch with the child? So the 3 C's of screen time, what are they? Clear limits about screen time. Second, content should be high quality content, and co-viewing should be a norm. That should be asked regularly. We do not talk about screen time in routine well child visit. The moment we start asking questions about it, parents may feel conscious. At least டாக்டர் கிட்ட போய் பயந்துகிட்டாவது அவங்க வீட்டில் போய் குறைக்கிறதுக்கு வாய்ப்பு இருக்கு. And emphasize importance of responsive caregiving in early childhood. This is one message that we have to convey to all parents recurrently. The best toy that the child can have is you, the parent, and the best time you can give your child is your time. What is very necessary? Read with the child, go outside and play with the child, and follow the IAP or the AAP guideline. Less than 2 years of age, 0 screen time. 2 to 5 years, 1 hour of quality content, co-watching. And this is a simple questionnaire called 7 and 7 exposure questionnaire, where there are 7 questions about screen time. They incorporate all the things: content, quality, co-watching, all those. And if the problematic screen exposure score is greater than 7, this family needs advice. And what are the alternatives? Spoil your child. A simple mnemonic to remember: what are the screen-free alternative? S is social time, P is play time, O is outdoor time, I is independent work. Help the child, make the child do home chores, take help from him. And L is literacy. Books reading among families is very important. So with that, we come to the conclusion of this talk. To summarize, excessive, unregulated, passive screen time in early childhood definitely impacts language, cognitive, and social emotional development. It can lead to obesity as well as sleep issues. It is a significant public health concerns in high income country as well as low income country. But despite adequate advisories and despite adequate guideline and despite enough research about it, a gap in implementation still remain. And pediatricians and child development professionals, we have to address this with urgency. Adhering to screen time guidelines less than 2 years of age especially is very important. Cultural factors should be factored in before we go on to advise parents about a 0 screen time. And encouraging parents to model healthy screen habits is very important. And for safe screen time, 3 C's. Clear limits have to be set. Content has to be high quality. Co-viewing has to be encouraged. And wherever possible, encourage screen alternatives. Thank you for your question.
Neurodevelopmental disorder and epilepsy are actually 2 phases of the same coin. Whenever you face a child with neurodevelopmental disorder and epilepsy, it's definitely a nightmare, not only for the children, but also for the treating physician. So going to the topic proper, NDD, neurodevelopmental disorder, is defined as group of conditions with onset in developmental period, including deficits that produce impairments of functioning. So broadly, it's classified into autism spectrum disorder, attention deficit hyperactivity disorder, and intellectual disability. In DSM-4, they don't allow the overlap between these 2 disorders. But in DSM-5, the overlap is allowed, and you get a new term called ADHD, that is autism associated with hyperactivity disorder. So it's not in DSM-5, it's actually an unofficial term. And the incidence of NDD in epilepsy patient is around 11 to 46% will have some kind of hyperactivity, and autism-like symptom in 18 to 30%. Whereas the incidence of epilepsy in NDD patients, ADHD 8 to 27% can have epilepsy, and in ASD around more than 1/3 patients will have seizures. So this is the intersecting triangle model, which depicts how the relationship between the NDD and epilepsy goes on. So take this disorder A as probably autism or ADHD in B. The core symptoms are separate actually. For autism it's separate, for ADHD it's separate, for seizures it's separate. But when you come down, when you come to the base from base above approach. For example, if you take this gene 5 and 6, where all the triangles intersect, this gene could be either a CDKL5 or FOXG or even SCN1A gene, where you can have all these symptoms together. They will have seizures, they will have autism-like symptom, they will have hyperactivity-like symptom. Not only genetic factors, the next level, lot of epigenetic and environmental factors, which we already discussed, like screen time, heavy metal exposure. All these alters this genetic mechanism and induces changes in cell and brain function, producing behavioral disturbances. So the previous term was epileptic encephalopathy, a cognitive and behavioral impairments due to epilepsy. This was the old term. Now the terminology is DEE, developmental and epileptic encephalopathy. It's a developmental delay caused by underlying genetic or structural causes along with epileptic encephalopathy, because the etiology per se can cause a neurodevelopmental disability that produces seizures, and refractory seizures in turn produces again neurodevelopmental disability. So this is the newer term. DEE is the ILA approved term now. So the previous classification of epileptic encephalopathy was based mainly on the age of onset. So these are the few syndromes. When it is infantile onset, there are Watahara syndrome, early myoclonic encephalopathy, West syndrome, Dravet syndrome, and epilepsy of infancy with migrating focal seizures. The later onset is Lennox-Gastaut, Landau-Kleffner, and Rasmussen syndrome. So this is a Sankey diagram which shows the phenotypic variant on the right side and the genotypic variant on the left side. There is a lot of overlap between these two. For example, if you take a Dravet phenotype, the most of them is due to SCN1A, but can also be due to other genes like GABRA1 and CDHL gene. And on the similar hand, if you take SCN1A, the majority will produce Dravet, but few patients can present with syndrome of migrating focal seizures or even West syndrome, or rarely even Lennox-Gastaut syndrome. So there is a lot of genotypic and phenotypic overlap. A single phenotype may be due to multiple genes, or one genetic defect can produce multiple phenotypes. So few case reports about each syndromes. Watahara syndrome, this is a classical report, a 9-month-old female, third child born to non-consanguineous parents, normal delivery, no birth asphyxia, global delay. The child started having tonic spasm from 1 month of age and myoclonic jerks from 2 to 3 months. So the child was microcephalic, had spastic weakness of all 4 limbs. There was no organomegaly. And in MRI, you can see the agyria pachygyria complex here, focal migration and anomaly, and EEG was full of burst suppression pattern. This is the classical presentation of Watahara syndrome. Almost the early myoclonic encephalopathy will have a similar picture, but here the myoclonic seizure starts earlier rather than the tonic spasms, and the etiology is mostly inborn error of metabolism rather than a migration anomaly. Otherwise, they look very similar. The next common syndrome is West syndrome. The usual age of onset is 3 to 7 months. They will have a triad of spasms. You can see the child. This is the classical flexor spasm occurring in clusters, associated with mental retardation, in EEG showing a Hibbs arrhythmic pattern. This is the triad of West syndrome. If you see this child, it looks very subtle actually. When the child is lying down, you feel that's a very subtle movement. Usually these kind of spasms occurs when the child gets up from sleep, and it occurs in clusters. So when you ask the child to lift up, you just carefully watch. The child goes in over a violent extensor spasm. The child is having recurrent extensor spasms. So the etiology could be either cryptogenic, or it can follow a tuberous sclerosis patient. And this child is HIE sequelae child, migration anomaly, infection, or inborn error of metabolism. So whenever you see a child with infantile spasm, so look at this child here. You have to look for hypopigmented patch here. And this child also had a ashy leaf macule over the back of right knee. So you have to, that is the only neurocutaneous marker which can be elicited in an infant, because all this adenoma sebaceum, Sjogren patch will appear later. And the same time, you have to look at the parents, because being an autosomal dominant condition, either of the parent, you have to look for adenoma sebaceum. They may be symptomatic or asymptomatic. Either of the parent can have these kind of skin lesions. Then MRI shows a classical subependymal nodules, and this is probably a subependymal giant cell astrocytoma. These patients are very prone for these kind of tumors, and they need a regular follow-up every year. You have to do an MRI, or at least every 2 years. And this is the hypsarrhythmic pattern of EEG. So management is mainly steroids. Previously, say about 5-6 years back, we have been using ACTH. Now oral steroids, oral prednisolone have been shown to be very or as equally effective as ACTH. The dose is around 2 to 4 milligram per kg. You have to give for 2 to 4 weeks. Then you have to follow with a EEG normalization. If the EEG gets normalized, you can gradually reduce it to over another 4 weeks. Vigabatrin, especially, it's available now. It's useful in tuberous sclerosis group. Whenever you see a child with tuberous sclerosis, we start straight away with vigabatrin. Rarely in refractory cases, we combine both steroids with vigabatrin. Pyridoxine, valproate, lamotrigine, topiramate are second line agents in this. Prognosis, good prognostic indicators are early treatment. Again, I emphasize the spasm should be treated early. There are very many number of studies which have clearly shown that early treatment improves the cognitive outcome of the child. Cryptogenic etiology, normal prior development, and EEG normalization after immunotherapy are favorable prognosis. Normal development occurs in only 15 to 25%. Intellectual disability is seen in 60 to 80%, and refractory epilepsy in 25 to 50%. And few chunk of patients may evolve into the next syndrome of LGS. So Dravet syndrome, it's another example. Here is a child, second child born to third-degree consanguineous parents. Normal milestones, initially febrile seizures at 2 years of age, and now with myoclonic and tonic seizures for the past 1 year. He actually presented with this symptom. If you closely watch the child is seizing throughout. He is having non-convulsive status. So he was recently started on a drug which precipitated this. Any takers? What drug would have precipitated a non-convulsive status in a child with Dravet syndrome? So usually sodium channel blockers. He was started on phenytoin. So phenytoin, carbamazepine, oxcarbamazepine, all these sodium channel blockers are contraindicated in Dravet syndrome, and they may even precipitate a non-convulsive status. So this is the EEG picture showing a continuous ictal pattern in the EEG. The next syndrome is a Lennox-Gastaut syndrome, bit older age group. It can be due to either cryptogenic, secondary, or follow a West syndrome. Multiple types of seizures, tonic, intellectual deterioration will occur. Here again, non-convulsive status is common, and EEG shows slow spike and wave, and they are notoriously resistant to treatment and poor outcome and poor prognosis. So this is the EEG showing a slow spike and wave of LGS. So another important syndrome is Landau-Kleffner syndrome. This everyone should give some attention. Here the child will be absolutely normal up to 2 to 8 years. The child seizures are very subtle. They may have one or few seizures, or completely seizures will be under control. Suddenly they will bring the child that the child is not speaking. So this child was apparently normal. For the past 2 months, he is not speaking at all. This is auditory agnosia. They won't respond to your verbal. They don't have a verbal comprehension. They won't respond to you. If you miss the history, they may look like an autistic child, to be frank. It's a very close differential of autism. But there is a spectrum of disorders like this, wherein the EEG is the only way to diagnose this. That too, you have to go for a sleep EEG. The sleep EEG shows electrical status epilepticus. Almost 80 to 90% of sleep EEG will be occupied by spike and wave. So another spectrum is continuous spike wave stupor. Here, what is the difference is, there in CSWS, you will have not only language regression, there will be global regression and behavioral abnormality, and seizure frequency will be very high. One important thing is they respond very well to steroids, like your infantile spasm. So this child responded very well to steroids. So this is his initial EEG. The sleep record, almost the entire record is like this, almost 90 to 100% pages were occupied by the discharges. And this is the EEG normalization after 2 weeks of steroids. So they require long-term steroids, anti-epileptic also. But anti-epileptic in alone doesn't work in this situation. Whatever anti-epileptic you give, the EEG won't normalize. Anything useful for generalized epilepsy like sodium valproate, levetiracetam, you can use. Another interesting syndrome is Rasmussen syndrome. Here, see the child is having these kind of facial motor seizures for months together. They come with intractable partial motor seizures, progressive hemiparesis, progressive cognitive decline, and CT MRI shows a progressive cerebral atrophy. Usually the etiology, whatever autoimmune workup, it will come as negative. And these are other group of disorders, they respond to steroids. But one thing in Rasmussen is the initial response will be very good, but most of them go in for relapse, and ultimately they end up with surgery like hemispherectomy. So this is the MRI showing atrophy on the left side, and the hyperintensity shows the disease is still active. This patient, when actually had a beautiful response to steroids, then he landed up with hemispherectomy. So these are the older classification or the phenotypic classification. But what are we doing now? Now the entire ILA classification is based on the genetic reports. So D68, SCN1A, it's a spectrum of disorder. Previously, we thought only Dravet syndrome are associated with SCN1A. Now even a simple and complex febrile seizures, GFS plus, intractable childhood epilepsy with generalized tonic-clonic seizures, and rarely even LGS, infantile spasm, and DUS syndrome can have SCN1A mutation. The next is D7 due to KCNQ2 mutation. It is also encompasses a spectrum of disorder like self-limited familial neonatal epilepsy, neonatal DEE, neonatal encephalopathy with non-epileptic myoclonus, and isolated intellectual disability. So the next one is GABRA D19. Here also the spectrum includes JME, GFS plus, epileptic encephalopathy and IgE. And D66 is PAX2. The PAX2 seizures, they respond well to pyridoxine. And ACTL6B, it's otherwise called epileptic encephalopathy, early infantile epileptic encephalopathy 76. So it is just renaming the old disorder, or does it have any practical implication? Do you think it's a old wine in a new bottle? Not at all. Actually, the practical implication is now the era of precision medicine. Whatever genetic test you do, that helps us in guiding the therapy. As I showed in the previous case, like Dravet syndrome, in SCN1A, you have to avoid this phenytoin, carbamazepine, oxcarb, lamotrigine, vigabatrin. And because most of these children will be needing a polytherapy, they won't respond to a single drug. The drugs to choose or how wisely you choose makes the difference. So SCN1A, they respond well to valproate, clobazam. Stiripentol is not available. Topiramate, cannabidiol is available. Fenfluramine, that is also not available. So valproate, clobazam, topiramate, and cannabidiol makes a good combination in a stepwise approach. You have to avoid sodium channel blockers. Whereas case in Q2 or SCN2A, one more variety of epilepsy, they respond well to your sodium channel blockers. Sometimes you tend to start them on valproate or phenobarbital, which will worsen the seizures in this condition. So those drugs has to be avoided. Whereas in GRIN2B, ketamine, valproate and benzodiazepines, and GABRA1 epilepsy, valproate, clobazam, topiramate, and levetiracetam are the drugs of choice. This you have to keep it as a ready reference, or then and there you have to refer, because there are hundreds of DEs now. DE 1 to 98, I suppose. I think I have hardly seen it as crossing 100. Probably near future, it will be crossing 100 also. So for each epilepsy, it's a precision, tailor-made treatment rather than one drug for all. In refractory cases, cannabidiol, though the cost is a bit high now, it's coming down. You can use it in Dravet syndrome, LGS, and tuberous sclerosis, and of course ketogenic diet, which is a age-old treatment. So one more syndrome which is very close to the autism is Rett syndrome. This occurs only in females because the male infant, they don't survive because it's X-linked and a single X with the mutated MECP2 gene is hard to survive, though MECP2 gene manifestation in males has been reported, but it's very, very less. They have regression after 6 to 18 months. They will be absolutely normal, or a slight floppiness may be there up to 1.5 years. The first thing is they have loss of purposeful hand movements and communication. They will have stereotypic hand movements. So if you see the child, that hand writhing movements will be there, and rocking movements of this child. Actually, this child presented with severe hyperventilation. Irregular breathing will be the patient can have a hypopnea, apnea, or a hyperventilation can be the. Both children have seizures, and there can be late motor impairment. So the spectrum is classical Rett is due to MECP2. Both the children are MECP2 positive, or a variant Rett can be due to other gene mutation like CDKL5 or FOXG1. And severe neonatal encephalopathy and PPMX syndrome, that was the one which I was telling about, which can occur in male. It includes pyramidal sign, Parkinson features, psychosis with macroorchidism, almost simulating a Fragile X syndrome. Treatment, the drug trofinetide, it's FDA approved in 2023. It's not available in regular market here. Gray market rate is very high, so I haven't used this drug so far. So autism with seizures, this is a final talk. It has a biphasic distribution. The seizures are more common in the early age group, and are about later, when the autism is well settled in the later child group from 8 to 10 years of age, again the incidence of seizures increases. So this could be either an idiopathic autism like this, or a genetic variance with proven D1A or MEF2C. So everything nowadays, the classification goes on with genetic classification. Whatever myopathy, muscular dystrophy, congenital myasthenic syndrome, the previous classifications are being outdated because it doesn't help us in deciding the treatment. So everything goes by the genetic classification. So the autism has a lot of comorbidities, not only seizures. They can have sleep disorders, motor coordination problems, sensory issues, microcephaly, intellectual disability, tics, and migraine headaches. So one important practical issue is whether you have to treat all autism children with EEG abnormality. So autism and EEG abnormality is found in 20 to 60% of individuals with autism, and epileptiform activity can be present even without clinical seizures. So the common EEG abnormality could be either a focal discharges or a florid EEG, as is shown in the LKS or CSW spectrum, showing a entire sleep will be occupied by the spike and wave pattern. And EEG is not used, that we know. 20 to 30% of autistic individuals develop epilepsy. EEG can help monitor risk for epilepsy in ASD. It's helpful if there is a developmental regression. So in practice, how to go about in a child with autism and EEG abnormality. So the first thing is, when a child with autism with normal behavior and development, there is no clinical seizures, even if the EEG is abnormal, subtle abnormality like focal spikes, focal sharps, AED is not recommended. Whereas if an autism with confirmed clinical seizures, if there is seizures is there, whether the EEG is normal or abnormal, if there is clinical seizure is there, AED is recommended. And another group is with regressive type of autism and associated EEG abnormality amounting up to electrical status epilepticus of speech, sleep, and clinical seizures may not be there, but here again you can consider AED, give a trial of AED for 2 to 3 months and see whether there is improvement in their behavior pattern. And autism with suspected absence of staring spells, EEG should show a significant generalized discharge. Though there is no clinical seizures or documented seizures, here again it's recommended. But it is not recommended with non-specific symptom for just hyperactivity or any other behavioral abnormality. Mild EEG abnormalities can be ignored in this group of children. So coming to the last one, the take-home message, the NDD and epilepsy have shared genetic and epigenetic etiology. Early identification and treatment of one will improve the outcome of other condition. This is especially true in case of infantile spasm and LKS and CSW spectrum, where it is clearly shown that treatment, early initiation of immune therapy improves the cognitive outcome. On the other hand, in autistic children, The early intervention reduces the future incidence of epilepsy as well, though there is no much of the evidence. Hypothetical explanations has been given. I would try to spend some time on the genetic identification helps in targeted therapy, especially in epilepsy. So genetic testing should not be the first one in a child with epilepsy. Keep it as a last one. Before you jump on to do a genetic test, just characterize a proper history, proper examination, good recorded EEG with a good report. Everything makes a lot of difference. Only when the child is really refractory to 2 to 3 drugs, there is associated neurodevelopmental abnormality. You don't have a obvious etiology like HIE or hypoglycemic sequelae, then definitely genetic testing will be very useful. I think we have many pediatricians who are very enthusiastic in genetic testing, and I have seen even in pseudo seizures they are going for genetic testing. So first determine what it is, then you can gradually build upon. That is one point. And as I already emphasized, anti-epileptic drugs in autism in selected situation. Thank you, Anandal.
Warm thanks to all of you for joining us till the end, my session being the last. I'll keep it very quick, brief. I'm sure I'll finish in under 10 minutes. So moving on to the topic of today's presentation, effectiveness of parent-mediated interventions at Pixie. So what am I about to talk? I'll be talking about how effective are the interventions we are giving at Pixie. So coming to the framework, I'll be talking about Pixie model, the effectiveness, group interventions which we are doing, the collaboration with schools, our learnings, and conclusion. So Dr. Russell was talking about the Vellore model. He was talking about what they're doing at CMC Vellore. So when I came to Salem, when we started our Pixie, we were thinking how we can extrapolate the Vellore model in Salem and how we can extrapolate the institutional model in a private setup like SKS Hospital. So what we did do is that we tried, it was in CMC Vellore, it is an intensive program where children will be admitted for a period of 3 months, which is not really feasible in our setting. So we did start trying in an outpatient basis. So we invite children and families to come together for intervention. So you can see a mother is training the child and a therapist is here to assist the mother in training. So here, mother is acting as a co-therapist where we train the mother to train the child. So this is what that is happening at our intervention. So interventions are very transparent. At every step, we involve parents in the intervention. So we did do that. The duration of interventions is somewhere we give around 3 to 5 days a week for 3 months based on the needs of the child, needs of the family, severity of autism spectrum symptoms. We decide on how many number of days the child has to come here to the therapy center. So, and we also follow a curriculum model, which is called Carolina curriculum, as Dr. Russell mentioned, and it is individually tailored based on the needs of the child. And the duration of intervention is somewhere around 1.5 to 3 hours based on the needs of the child. So how does it go? Every child who comes to Pixie, what do? We do clinical evaluation, structured assessments, and then we plan our intervention program. So we do clinical evaluation, it will be both observing a child and a parent interview, followed by structured assessments, Bailey, which gives the developmental age across domains of cognition, receptive communication, expressive communication, fine motor and gross motor skills. As Dr. Russell mentioned, we do assessments which are validated in Indian settings. We largely go only for CARS and ESA. And for intervention, we do Carolina curriculum. I'll be showing up the Carolina curriculum shortly. And the interventions, we do combination of play, behavioral, and developmental interventions. So quickly running through the elements of interventions. When we talk about intervention, what do we do in OT? What do we do in speech? So many pediatricians do ask us how exactly you devise your intervention. So many times we actively involve mother to allow mother to engage the child through play-based activities like playing a large social games like asking to play peekaboo, tickle game, through social games. We are going to work on the pre-linguistic skills, which is eye contact imitation, joint attention, gestures, and receptive communication, and following the child's lead. So in the play, we ask the parent to completely be there with the child, following the child's lead, and then to then imitate and then expand the play behavior and expand the level of communication of the child. And context-based language stimulation, for example, when the child is given bath, like mother can teach body parts, mother can teach like self-help skill of bathing could be taught. So context-based language stimulation and giving opportunities to facilitate communication, because many times we don't give opportunities for child to communicate the needs. So creating more opportunities and improving the play behavior. Other important component which we follow is Jasper's model, where we help parent to improve the play behavior from simple to symbolic. Also sensory integration approaches. Sorry. And for the goal setting, so what we do for goal setting is that we actively involve the parent in goal setting. The next developmental goal will be set based on the Carolina curriculum and what is the need of the family. We all largely include the needs of the family in the goal setting. And improving functional communication, especially for non-verbal children or children whose verbal skills are very low, we go for AAC, alternative augmentative communication. Structured routine with emphasis on visual schedule and use of behavior therapy principles. So as mentioned earlier, parent is training the child completely, and parent here is setting the goals for the child. As a result of this, parent gets empowered how to train the child at home. So this translation in the home settings, the improvements which happens here in therapy could be generalized in home setting if the parent is going to get trained in the department. So this is what happens. So we do initially start with 1-to-1, and then we do build a cohort system where 2 children are trained or 3 children are trained along with the parents. So this is how continuity of care happens at the department. So how we showcase the improvements to the parents? We do invite them for case conference where we present after 3 months. We do re-evaluate the ESA and CAR score. And again, repeat the Carolina curriculum after 3 months to show the level of improvements the child has made across developmental domains after 3 months of interventions. So this was already showed. So this is at the baseline, this was the level of the child, developmental skills of the child. And after 3 months of interventions, all the green shaded areas represent the developmental gains made by the child. So this is similar to the Velour model. The only difference is that we have tried to extrapolate in our setting, and a lot of flexibilities we have made for the families so that families will be benefited with our model. And to look at the effectiveness of interventions. So this is an unpublished data from our department. We are yet to publish this. We tried analyzing how much is the improvements in our setting. So quick socio-demographic profile of children. So majority of the children who are referred to us are between 2 to 3 years and 4 to 5 years. And the most common symptom to which the children are referred to us is speech delay. This is an important take-home message. Most common, 80% of children are brought to us with diagnosed symptoms of autism only because of the symptom of speech delay, which means every child with the symptom of speech delay requires active screening for autism spectrum disorder. And when we understood the effectiveness of intervention, what we understood is that the pre-intervention CAR score, significant drop of around 8 points was noted at the end of 3 months, which is very significant, 8-point reduction in CAR score. And when we look at how many children, so we know that in CARS we have categories of mild, minimal, mild to moderate, and severe. So how much this 7-point reduction, what does that mean? And to our surprise, we did understand that children who were initially in the mild to moderate category, 77% of the children moved to the minimal category or no symptom category, and 27% children remained in the mild to moderate category. And also children with severe symptoms, 11%, which is one child alone, moved to the minimal to no symptom category. You may ask me a question now. So is it possible with 3 months intervention, severe symptoms drastically coming down to minimal? So this child, actually, a child was in the waiting list for 3 months where we have given home program for the family. So total duration of intervention for this child was actually 6 months. So because of which this child moved from the severe to the minimal category. And 72% of the severe category children moved to the mild to moderate category, and 16% children remained in the severe category. So how effective are the interventions? So we did find in our study that overall gains made by children with mild to moderate symptoms. So how many months of developmental months of gains made by children? You see average number of 10 to 12 months gains made across all developmental domains in a period of 3 months. So in a period of 3 months, children with mild to moderate are having improvements of 10 to 12 months, which is very significant. And for severe category, you will find somewhere between 5 to 7 months of developmental gains for children with severe symptoms. So we also understood, is the p-value significant here? No. Which means regardless of the severity of autism, children make developmental gains across all domains. Even the severe child make developmental domain, which is actually very which gives us lots of hope and optimism that every child will benefit with interventions. So again, talking about the effect size, our effect size was very significant, somewhere between 0.5 to 1.1. Actually, it means medium to large effect size. And also for children with mild to moderate autism, we saw the large effect size. So what are the predictors of outcome in our study? We understood that absence of regression. If the child doesn't have history of regression, it was a good prognostic factor, and better cognition at the baseline was again a good prognostic factor. So when comparing with a parent article with the Velour model, so what does this Velour model say? The overall intervention gains made by the child is around 9 months for mild to moderate and 7 months for severe children, which is actually similar to our study. So we are able to translate the same model in our setting. So this is some of the group interventions we offer. We make sure that every parent remains the main co-therapist for every intervention that we offer. You will see all the parents are sitting near the child and they're doing the interventions. Just the therapist is at the back to facilitate the parents. So all the parents are sitting here. And we also do the group interactive series program. And this is an educational interventions. We believe in starting educational interventions early for these children so that the improvements are, we are seeing improvements in educational domain as well. And these are the interactive series. We train parents often on how to train the child at home, teaching them a lot of concepts and translating the intervention effects at home. And the latest addition to the department is the social skills training, which we have introduced, where we start training children early on theory of mind concepts, symbolic play, how to improvise the play behavior, how to work on assertive communication. A lot of social skills training program is just started in the department. And coming to talk about brief intervention. So for parents who are not able to come to Salem or come to Pixie for 3 months of interventions, what do we do? So we get referrals from Krishnagiri, Dharmapuri, Namakkal. So what do we do for those children? We offer brief interventions, which the duration of intervention is just for 1 hour. I sit with a parent, either in a group or a single parent. We use pen and paper method, just train the parent saying what are the techniques, how to train at home, just 1 session. And to our surprise, we understood that many parents have started working at home, and we saw significant improvements after 1 session of home program. And we are yet to finish the data analysis for this arm, brief intervention arm. We do share a lot of reading materials with parents, what are the targets to work on, and then help the parent find intervention center at their own place. And then we follow up the child with CAR score at 6 weeks and 3 months. And we do understand that even the low intensity interventions, giving one home program for a parent, empowering the parent, makes a huge difference in the life of children. What are our key learnings? Speech delay is the most common presentation of children with autism. And any child with developmental delay, and a parent expressing concern about developmental delay has to undergo detailed clinical evaluation, structured assessments, and tailored interventions. And as research says, and we do see in our clinical practice, there is a gap between a parent expressing delay and the referral. So this gap has to be filled with early identification and early intervention. A parent expressing concern immediately has to be evaluated. And starting home interventions early. We need not wait for the parent to come to therapy, starting home-based interventions early. And as the speaker spoke, the stopping screen time and increasing home-based stimulation remains an important and effective interventions. And many times it is thought that enrolling in school is enough for the child. No. skill building can happen and does happen only in the therapy center, and only socialization can happen in the play school. So we must emphasize both on interventions and early school integration. Parent-mediated interventions are seen to be very effective and feasible. And supporting and empowering parent at every step must be needed. This reduces the burnout in families. And liaison with the referral pediatrician and the schools is very important. At the end of the day, I largely believe in giving hope to the families with which many of us fail. So we need to give hope to the families about. So now the concept is like 15 to 20% of the children move out of spectrum with early intervention. There's a lot of hope, and children with ASD, many children are able to lead a normal life and move out of spectrum. So there's a lot of hope with early intervention. And collaboration with schools is which we actively do in our department. We find inclusive schools for children, and we connect with the teacher through either phone call or a letter to understand the skill deficit in school environment, and we try to accommodate the child in classroom. So some parents, some teachers program has given us a lot of good impact on early identification, and also helps us to break stigma. Basically, it is just one simple step to break stigma and to empower them with early identification, teaching them how to pick up and send to their pediatrician. So what would be my suggestions for a busy office pediatrician practice? It's very, very important to address the screen time. Screen time before 2 years is very detrimental to child's development. It has to be addressed in every well baby visit clinics. And emphasize on gadget-free feeding practices. Feeding is is the main reason, as Dr. Srinivas Raghavan mentioned, is the main reason why children are introduced to screen time. We have to address it. And early developmental stimulation, which is actually a forgotten concept. Parents are working, they don't have time for children, and parents taken care by grandparents. They know absolutely developmental stimulation. Emphasize on developmental stimulation. Talk to the child, sit with the child, play with the child. Simple, nothing, no more. So our every case sheet of mine will have only first line: stop screen time, stimulate the child. So that is the only thing which we need to empower the parent from the start of the well baby visits. And active screening with MChat. Very, very important message. Every child with a speech delay, there's no time to wait. Absolutely no time to wait. So even if a child says, a child is brought to us by 1 year with having no single word, or with early markers of no bye-bye, or no joint attention, actively screen with MChat and do the early intervention, at least as the parent to stop the screen time, and as the parent to stimulate the child at home and do a close follow-up, if not a referral. Even this would help and benefit the child, and alerting the family at that point is very important. And largely the concept has moved from 3 years to 2 years. So early intervention during the critical period of brain development before 2 years. It's when you identify any delay at any age before 2 years, don't wait. Don't wait. Stimulate the child. Look for early markers. Look for the markers of autism, and then suggest active interventions, early interventions for the family. So to conclude, early identification and early interventions during the critical period, which is before 2 years, plays a pivotal role in improving developmental outcomes of children. And largely, even training the parents remains very feasible, effective in an outpatient setting like ours. And early interventions will help improve the children, improve the quality of life, reduce the economical burden of the family, and helps children move out of spectrum, which gives us a lot of hope. And liaising with the pediatrician and the schools is very imperative. These are the concluding remarks. Thank you all. Thank you all for joining us today.